Welcome to this video entitled Tuberculosis. Let's begin with the history of tuberculosis. Tuberculosis, abbreviated as TB, is an ancient disease with evidence of spinal tuberculosis in pre-Columbian and early Egyptian remains. Tuberculosis emerged as a major health problem in the 17th and 18th centuries when crowded living conditions of the Industrial Revolution contributed to its epidemic spread throughout Europe and the United States. Early physicians referred to tuberculosis as phthisis, derived from the Greek term for wasting, because its clinical presentation consisted of weight loss, cough, fevers, and hemoptysis. The etiologic agent was identified in 1882 when Robert Koch isolated and cultured Mycobacterium tuberculosis and demonstrated its infectious nature. With this knowledge, early treatment in the mid-1800s to the early 1900s consisted of placing patients with TB in a sanatorium for bed rest and fresh air. With the advent of radiographic film, pulmonary cavitary lesions were found to be a pivotal component in the evolution of the disease. Therapy included pneumoperitoneum, thoracoplasty, and plombage to reduce the size of the cavitary lesion, and some of these therapies are still used today for severe and refractory cases. The modern era of medical tuberculosis therapy began in 1944 with the discovery of streptomycin and, shortly thereafter, p-aminosalicylic acid. Addition of isoniazid in 1952 and rifampin in the late 1960s greatly increased treatment success and provided hope for the eventual elimination of tuberculosis. However, multi-drug-resistant tuberculosis, abbreviated as MDR-TB, emerged in the 1990s as a threat to the control of tuberculosis in the United States and other countries. In the subsequent decade, published reports described the worldwide emergence of extensively drug-resistant tuberculosis abbreviated as XDR-TB, and, more recently, the emergence of totally drug-resistant TDR, or super-XDR-TB strains. Because tuberculosis strains become increasingly resistant to currently available agents, the likelihood of achieving global control and elimination of this disease are diminished. Therefore, a high index of suspicion for tuberculosis, rapid pathogen identification, susceptibility testing, patient isolation, and appropriate antimicrobial therapy are critical to prevent further development and spread of drug-resistant tuberculosis.
We will now look at incidence and epidemiology. Assuming lifelong infection, approximately 2.0 billion people, that is 30% of the world's population, are infected with Mycobacterium tuberculosis. Tuberculosis is the second most common cause of death from an infectious disease in the world after human immunodeficiency virus (HIV) and acquired immunodeficiency syndrome (AIDS). Globally, there were an estimated 9 million new cases of tuberculosis in 2013. The majority of these new cases were identified in the Southeast Asia, Western Pacific, and the African regions. The countries with the largest number of new cases were India, China, Nigeria, and Pakistan. Approximately 13% of the new tuberculosis cases in 2013 were identified in patients infected with HIV, with the African region accounting for 78% of these cases. In 2013, approximately 1.1 million deaths were reported among HIV-negative cases and 0.36 million deaths were reported among HIV-positive cases. These deaths include 510,000 women and 80,000 children. In the United States, 9,421 cases of tuberculosis were reported in 2014, and the incidence rate was 2.96 per 100,000 population, which represents the lowest recorded rate since national reporting began in 1953. However, the incidence rate remained substantially higher than the national goal for elimination of tuberculosis, that is less than 1 case per 1 million population. 21 states reported increased numbers of tuberculosis cases in 2014, and 4 states, that is, California, Texas, New York, and Florida, accounted for 51% of all tuberculosis cases. The number of tuberculosis cases and the incidence rates declined for both foreign-born and U.S.-born persons, but foreign-born and ethnic and racial minorities continue to be disproportionately affected by tuberculosis in the United States. In 2014, 66% and 34% of all tuberculosis cases were reported in foreign-born and U.S.-born persons, respectively, and the tuberculosis rate was 13 times higher in foreign-born persons compared with U.S.-born persons, 15.4 versus 1.2 per 100,000 population. 5 countries accounted for more than half of TB cases in foreign-born persons: Mexico, that is 21%, the Philippines, that is 12%, India, that is 8%, Vietnam, that is 8%, and China, that is 7%. Tuberculosis rates for Hispanics, non-Hispanic blacks, and Asians were 8.5, and 30 times greater than the rate for non-Hispanic Caucasians. Among U.S.-born persons, the greatest number of tuberculosis cases was reported in blacks. Among persons with tuberculosis whose HIV status was known, 6% of these patients were co-infected with HIV.
In the United States, 9.3% of isolates from patients with no previous history of tuberculosis were resistant to isoniazid in 2014. Resistance was 7.5% in US-born individuals and 10.2% in foreign-born individuals. Globally, there were approximately 480,000 cases of multidrug-resistant TB, defined as resistance to both isoniazid and rifampin, resulting in 210,000 deaths in 2013. The largest number of multidrug-resistant TB cases were reported in China, India, the Russian Federation, and South Africa. In the United States, 67 cases of multidrug-resistant TB were reported in 2014. The overall proportion of multidrug-resistant TB cases in the United States has been stable over the last decade, ranging from 0.9% to 1.3%. Foreign-born persons accounted for 85% of these multidrug-resistant TB cases. The percentage of multidrug-resistant TB is approximately 7 times higher for persons with a previous history of tuberculosis compared with persons with no previous history of tuberculosis. Several conditions and risk factors for persons with increased risk of infection with drug-resistant TB are shown in Table 68.1. In the mid-2000s, XDR-TB emerged as another major threat to global health. The definition of XDR-TB is resistance to isoniazid and rifampin among first-line agents, resistance to any fluoroquinolone, and resistance to at least one second-line injectable drug, amikacin, kanamycin, or capreomycin. According to the World Health Organization, XDR-TB strains have been identified in 100 countries worldwide, and an estimated 9% of patients with multidrug-resistant TB have XDR-TB. One of the first reports described 53 patients infected with XDR-TB from South Africa. HIV status was known in 44 patients, and all of these patients were HIV positive. 55% of the patients had no prior history of tuberculosis treatment, and 98% died with a median survival period of only 16 days after collection of the first sputum specimen. In the United States, 49 cases of XDR-TB were identified between 1993 and 2006, and mortality was strongly associated with concomitant HIV infection. Since 2009, 15 cases of XDR-TB have been reported in the United States, and 11 cases were among foreign-born individuals.
Risk factors for XDR-TB include previous treatment for tuberculosis, HIV infection, homelessness, and alcohol use. In a retrospective analysis of patients with documented multidrug-resistant TB, emergence of XDR-TB was associated with baseline chronic disease and non-adherence to multidrug-resistant TB therapy. Treatment success is significantly lower for XDR-TB, and XDR-TB is associated with increased all-cause and tuberculosis-related mortality. However, treatment outcomes are significantly improved when later-generation fluoroquinolones are added to the treatment regimen for XDR-TB, even if fluoroquinolone resistance was demonstrated on susceptibility testing. The evolution of TB resistance continued in 2009 with the identification of strains that were reported to be TDR, which was defined as resistance to all first-line and second-line agents. 15, that is 10.3%, of 146 multidrug-resistant TB strains tested were found to be TDR-TB in Iran, and cultures remained positive in these cases after 18 months of treatment with second-line agents. All of these TDR-TB cases were HIV negative. This report illustrates the critical need to develop new and effective agents for the treatment of tuberculosis caused by MDR, XDR, and TDR strains. Pause the video and carefully scrutinize Table 68.1 summarizing conditions and risk factors for persons with increased risk of drug-resistant tuberculosis before advancing to the next slide.
Next we will look at the etiology of tuberculosis. Tuberculosis is caused by M. tuberculosis, an aerobic, non-spore-forming bacillus that resists decolorization by acid alcohol after staining with basic fuchsin. For this reason, the organism is often referred to as an acid-fast bacillus, abbreviated as AFB. Mycobacterium tuberculosis is different from other bacteria in that it replicates slowly, once every 24 hours instead of every 20 to 40 minutes as with some other bacteria. The organism thrives in environments in which the oxygen tension is relatively high, such as the apices of the lung, the renal parenchyma, and the growing ends of bones. Next we will look at the transmission of tuberculosis. Mycobacterium tuberculosis is transmitted through the air by aerosolized droplet nuclei that are produced when a person with pulmonary or laryngeal tuberculosis coughs, sneezes, speaks, or sings. Droplet nuclei may also be produced by other methods, such as aerosol treatments, sputum induction, bronchoscopy, endotracheal intubation, suctioning, autopsy, and through manipulation of lesions or processing of secretions in the hospital or laboratory. These droplet nuclei, which contain 1 to 3 Mycobacterium tuberculosis organisms, are small enough, that is 1 to 5 micrometers, to remain airborne for long periods and reach the alveoli within the lungs when inhaled. Tubercle bacilli are not transmitted on inanimate objects, and organisms deposited on skin or intact mucosa do not invade tissues. Several factors influence the likelihood of transmission of Mycobacterium tuberculosis, including the number of organisms expelled into the air by the index patient, the concentration of organisms in the air determined by the volume of the space and its ventilation, the length of time an exposed person breathes the contaminated air, location of the exposure, that is small room versus outdoors, and the immune status of the exposed individual. Family household contacts, especially children, and persons working or living in an enclosed environment, e.g., hospitals, nursing homes, or prisons with an infected person are at a significantly increased risk for becoming infected. If the index case is smear positive, 50% of household contacts will have a conversion of the tuberculin skin test from negative to positive. However, if the index case is smear negative, only 5% will become infected. Individuals with impaired cell-mediated immunity, such as HIV-infected persons or transplant patients, are more likely to become infected with Mycobacterium tuberculosis after exposure than persons with normal immune function. Travelers to tuberculosis endemic areas with international medical exchange programs are also at risk of tuberculosis infection, regardless of involvement in direct patient care activities or duration of stay.
Several techniques are effective in limiting airborne transmission of Mycobacterium tuberculosis by reducing the number of droplet nuclei in a given airspace. Adequate room ventilation with fresh air is very important, especially in the healthcare setting, in which 6 or more room air exchanges per hour are desirable. New construction or renovation of existing facilities should be designed so that airborne infection isolation rooms achieve 12 or more room air exchanges per hour. Ultraviolet irradiation of air in the upper part of the room can also reduce the number of viable airborne tubercle bacilli. All healthcare workers and visitors who enter the room of a patient with tuberculosis should wear at least N95 disposable respirators, and the mask should be molded to fit tightly around the nose and mouth. Patients with presumed or confirmed infectious tuberculosis should wear a protective mask when being transferred to another area of the institution or after hospital discharge until they are non-infectious. However, the most important means of reducing transmission of Mycobacterium tuberculosis is by treating the infected patient with effective anti-tuberculosis therapy. Next we will look at the pathogenesis of tuberculosis. Let's begin with latent infection versus active disease. Regarding latent infection, a clear distinction should be made between latent infection and active disease, that is, tuberculosis. Latent infection occurs when the tubercle bacilli are inhaled into the body. After inhalation, the droplet nuclei containing Mycobacterium tuberculosis settle into the bronchioles and alveoli of the lungs. Development of infection in the lung is dependent on the inoculum of organisms inhaled, the virulence of the organism, and the innate immune response of the host. In the non-immune, that is susceptible, host, the bacilli initially multiply unopposed by normal host defense mechanisms. The organisms are then phagocytized by alveolar macrophages and resident dendritic cells, but they may remain viable, multiplying within the cells for extended periods. After 14 to 21 days of replication, the tubercle bacilli spread via the lymphatic system to the hilar lymph nodes and through the bloodstream to many other organs of the body. Fortunately, certain organs and tissues in the body, such as the bone marrow, liver, and spleen, are resistant to subsequent multiplication of these bacilli. Organs with high blood flow and PaO2, such as the apices of the lungs, kidneys, bones, and brain, are favorable for organism growth and may lead to extrapulmonary disease. Organisms replicate for 2 to 12 weeks until they reach a concentration of 10⁻³ to 10⁻⁴, plateauing coincident with the development of a T-cell-mediated immune response in the host. CD4+ T cells produce interferon gamma, which is an essential cytokine for activation of macrophages and mycobacterial killing, as well as other cytokines. At this point, the patient has developed cell-mediated immunity, which can be detected by a reaction to the tuberculin skin test or interferon gamma release assay, abbreviated as IGRA, and bacterial replication is halted. In persons with intact cell-mediated immunity, activated T cells and macrophages may result in formation of a granuloma, a hallmark of tuberculosis, that is thought to represent a physical and immunologic barrier to control the infection and limit dissemination of the bacilli to the surrounding environment. Cells found within the granuloma include CD4+ and CD8+ T cells, B cells, neutrophils, macrophages, multinucleated giant cells, and fibroblasts. The organisms tend to localize in the center of the granuloma, which is frequently necrotic, and the tubercle bacilli may remain viable indefinitely within the granuloma. In addition, maintenance of the integrity of the granuloma allows for control of bacterial replication and depends on the immune status of the patient. Tumor necrosis factor, abbreviated as TNF, is a key cytokine that is critical for the integrity of the granuloma. Most patients with latent tuberculosis infection are asymptomatic with no radiographic evidence of the infection. In some patients, there may be a healed, calcified lesion on chest radiograph, but bacteriologic studies are negative. A positive tuberculin skin test or interferon gamma release assay is the only indication that the person has been infected with Mycobacterium tuberculosis. Individuals with latent tuberculosis infection are not infectious and thus cannot transmit the organism to other individuals.
We will now discuss active disease. In the majority of patients, active tuberculosis disease results from reactivation of a previously controlled latent infection, termed reactivation tuberculosis. It has been estimated that approximately 10% of individuals who acquire tuberculosis infection and do not receive therapy for the latent infection will develop active TB disease, and the risk of developing active disease is greatest during the first 2 years after infection. In a population-based tuberculin skin test survey conducted in Florida between 1997 and 2001, the rate of reactivation with latent tuberculosis infection but without HIV co-infection was 0.040 to 0.058 cases per 100 person-years. However, a recent study reported that 1 in 4 cases of active tuberculosis in the United States may be caused by recent transmission. The study included patients with culture-positive tuberculosis, and the Mycobacterium tuberculosis isolates were fully characterized by genotype. Clusters were defined as cases with Mycobacterium tuberculosis that were an exact match by genotype within specific geospatial zones. Cases that were both genotypically and spatially clustered were considered recent tuberculosis transmission, and cases that were not genotypically and spatially clustered were considered reactivation TB. Of the 36,860 cases where genotyping was performed, 8,499 cases, that is 23.1%, met the criteria for recent tuberculosis transmission. Groups at greatest risk for recent transmission were HIV-infected individuals, members of a minority group or ethnic race, men, individuals born in the United States, children 4 years of age or younger, substance abusers, and the homeless. These patients may have limited access to health care, resulting in delayed diagnosis and extended periods of infectivity.
Reactivation of tuberculosis in persons with latent tuberculosis infection is primarily a function of the immune status of the host. The ability of the host to respond to Mycobacterium tuberculosis infection is reduced by certain diseases, such as diabetes mellitus, silicosis, chronic renal failure, and diseases or drugs associated with immunosuppression, e.g., HIV infection, anti-TNF-alpha agents, organ and hematologic transplantation, corticosteroids, and other immunosuppressive agents. The likelihood of progression from latent infection to active tuberculosis disease is greater in persons with these conditions. HIV-infected persons, especially those with low CD4+ T cell counts, develop active tuberculosis disease rapidly after becoming infected. Up to 50% of these individuals may develop active disease in the first 2 years after infection. In addition, a person with untreated latent tuberculosis infection who acquires HIV infection will progress to active tuberculosis disease at an approximate rate of 5% to 10% per year. The relative risk for progression from latent infection to active disease is 1.6 to 25 times higher in patients treated with anti-TNF-alpha agents, depending on the clinical setting and the agents used. Physical or emotional stress, gastrectomy, intestinal bypass surgery, alcohol abuse, hematologic disease, reticuloendothelial disease, and intravenous drug use are risk factors for development of active disease. The elderly, adolescents, and children younger than 5 years of age are also at increased risk of developing active disease. Next we will discuss overview of drug therapy. Drug treatment is the cornerstone for management of patients with TB. In a patient with active tuberculosis, the overall treatment goals are to cure the individual patient and to minimize transmission of Mycobacterium tuberculosis. The primary goals of chemotherapy are rapid bacterial killing, prevent emergence of drug resistance, and eliminate persistent tubercle bacilli to prevent relapse. To accomplish these goals, treatment must be tailored to each patient's clinical and social circumstances to ensure adherence to and completion of treatment, that is, patient-centered care. Effective tuberculosis treatment requires a substantial period of drug therapy, and optimization of the initial treatment phase prevents emergence of resistance and ensures success of tuberculosis therapy. Current guidelines recommend 4 drugs for the initial 8-week treatment phase: isoniazid, rifampin, pyrazinamide, and ethambutol. The drug regimen and duration of the continuation phase depends on patient response, susceptibility of the isolate, host factors, extent of the disease, that is, pulmonary versus extrapulmonary, and drug tolerability. The shortest duration of therapy is 6 months, but longer durations may be required with drug-resistant strains. Because patients must be treated for months, directly observed therapy, abbreviated as DOT, is the preferred core management strategy to ensure adherence. In patients with latent tuberculosis infection, monotherapy with isoniazid for 6 to 9 months remains the preferred regimen, although other attractive options are available. And now we will move on to clinical presentation of active disease. Patient HG's history of cough, which gradually became productive, fever, night sweats, fatigue, and weight loss are classic symptoms of active tuberculosis. Cough may be non-productive early in the course of the illness, but with subsequent inflammation and tissue necrosis, sputum is usually produced and is key to the diagnostic studies. Sputum may contain blood, that is hemoptysis, in patients with advanced cavitary disease, which is particularly worrisome because cavitary lesions harbor high concentrations of organisms and the pulmonary location facilitates airborne transmission. Dyspnea is unusual unless there is extensive disease. Other symptoms of tuberculosis may include pleuritic chest pain and general malaise. In pulmonary tuberculosis, the chest radiograph usually reveals patchy or nodular infiltrates in the apical or posterior segments of the upper lobes, but changes may be observed in any segment. The patchy infiltrates on patient HG's chest radiograph are consistent with pulmonary tuberculosis. Cavitary lesions may be seen, however, these were absent in this patient. Moderate elevation of the white blood cell count with increased monocytes and eosinophils and anemia are the most common hematologic manifestations of tuberculosis. Patient HG had an elevated white blood cell count with increased monocytes, and he was also anemic. Many patients with active pulmonary tuberculosis have no acute symptoms, and a lack of symptoms may hinder diagnosis. In one study, approximately 50% of active tuberculosis cases without classic symptoms were misdiagnosed. More than one-third of the patients with active tuberculosis had no sweats, chills, or malaise, and fewer than 50% were febrile.
Cough was evident in 80% of these patients, and only 25% had hemoptysis. Although dullness over the apices of the lungs and post-tussive rales are expected in tuberculosis, less than one-third of these patients had any abnormal pulmonary signs. Similar findings were reported in another study. Absence of specific clinical symptoms underscores the importance of skin testing, sputum smears for AFB, and chest radiographs in suspected tuberculosis. Lastly, cases of active tuberculosis are often found after routine chest radiographs for other illnesses. Because many of the symptoms of tuberculosis also occur in persons with pre-existing pulmonary disease or pneumonia, they may be overlooked and not attributed to tuberculosis. The close contact with his coworkers, who have similar respiratory symptoms, and a geographic origin from Mexico are risk factors for tuberculosis in patient HG. In addition, studies have implicated cigarette smoking as a risk factor for tuberculosis. In a cohort study conducted in Taiwan, smoking was associated with a twofold increase in the risk of active tuberculosis. Furthermore, a significant dose-response relationship was identified for number of cigarettes smoked per day, number of years of smoking, and number of pack years smoked. Smoking impairs mucociliary clearance, decreases phagocytic pulmonary alveolar macrophage function, decreases intracellular production of tumor necrosis factor alpha, and causes iron overload in macrophages. These defects in host defense mechanisms increase the risk of active disease after exposure to Mycobacterium tuberculosis.
Next we will discuss the diagnosis of active tuberculosis. The tuberculin skin test (MANTU) method has been used as a diagnostic tool for infection with Mycobacterium tuberculosis for decades, but a positive skin test is not necessary for the diagnosis of active tuberculosis disease. The test is frequently referred to as the PPD, that is purified protein derivative test, which contains a protein prepared from a culture of the tubercle bacilli. Skin testing is performed by injecting 0.1 ml of solution containing 5 Tu of PPD intracutaneously into the volar or dorsal surface of the forearm. The injection is made using a 1/4 to 1/2 inch, 27-gauge needle and a tuberculin syringe. The solution should be injected just beneath the surface of the skin, avoiding subcutaneous tissue. A discrete pale elevation of the skin that is a wheel, 6 to 10 mm in diameter, is produced when the injection is performed correctly. If the first injection was administered improperly, another test dose can be given at once, selecting a site several centimeters away from the original injection site. If the patient has been infected with Mycobacterium tuberculosis, sensitized T cells are recruited to the skin site where they release cytokines. These cytokines induce an induration, that is a raised area, through local vasodilatation, edema, fibrin deposition, and recruitment of other inflammatory cells to the area. Typically, the reaction to the tuberculin protein begins 5 to 6 hours after injection, with maximal induration observed at 48 to 72 hours. Therefore, the test should be read between 48 and 72 hours after injection, because tests read after 72 hours underestimate the actual size of the induration. For standardization, the diameter of the induration should be measured transversely to the long axis of the forearm and recorded in millimeters. The diameter of the induration should be measured and not the erythematous zone surrounding the induration. An induration of at least 5 mm in diameter read 48 to 72 hours after injection is a positive reaction in an individual with a recent history of close contact with a person with active tuberculosis, a person with fibrotic changes on chest radiograph consistent with previous tuberculosis, organ transplant patients and other immunosuppressed patients, that is those receiving the equivalent of equal to or more than 15 mg per day of prednisone for longer than 1 month, or HIV-infected persons. An induration of at least 10 mm in diameter is a positive reaction with clinical conditions associated with increased risk for tuberculosis, such as diabetes mellitus, silicosis, chronic renal failure, malnutrition, leukemia, lymphoma, gastrectomy, jejunal bypass, and weight loss of greater than 10% of ideal body weight. In addition, an induration of at least 10 mm is considered to be positive in recent immigrants less than 5 years from countries with a high prevalence of tuberculosis, injection drug users, residents and employees of high-risk congregate settings e.g., prisons, nursing homes, or homeless shelters, healthcare workers, mycobacteriology laboratory personnel, and children younger than 4 years of age or infants, children, and adolescents exposed to adults in high-risk categories. The skin test is also considered positive for persons with an increase in induration diameter of at least 10 mm within a 2-year period. For individuals with no risk factors for tuberculosis, an induration of at least 15 mm is required for a positive reaction. It is very likely that Hg has been in close contact with persons with active tuberculosis, that is, his co-workers, even though they have not yet been diagnosed with active tuberculosis. When all factors are considered, the ppd of 14 mm should be considered to be positive in patient Hg. Patient Hg's positive reaction to 5Tu of ppd alone does not imply active TB disease. It only confirms that he has previously been infected with Mycobacterium tuberculosis. To confirm the diagnosis of active tuberculosis disease in patient Hg, Mycobacterium tuberculosis must be detected and isolated from sputum, gastric aspirate, spinal fluid, urine, or tissue biopsy, depending on the site of infection. As was performed in patient Hg, detection of AFB in stained sputum smears examined microscopically should be the first test to confirm the presence of mycobacteria in a clinical specimen. It is the easiest and fastest procedure that can be performed and allows preliminary confirmation of the diagnosis. Sputum samples for AFB stain and culture are best obtained early in the morning on at least 3 separate days. The cough reflex is usually suppressed at night, and the first early morning expectoration represents secretions accumulated in the chest overnight. The number of organisms in the morning sample is greater, and the diagnostic yield is higher. Smears may be prepared directly from clinical specimens or from concentrated preparations by placing the specimen on a glass slide under a microscope with a Zeil-Nielsen or fluorochrome stain, not a gram stain. Sensitivity of sputum smear microscopy is low because 5,000 to 10,000 bacilli per milliliter of specimen must be present for AFB detection in stained smears. Therefore, a negative AFB smear does not rule out active tuberculosis disease, and patients with active tuberculosis and negative AFB smears may facilitate transmission of Mycobacterium tuberculosis. Additional limitations of the AFB smear are its inability to differentiate among mycobacterial species and between viable and non-viable organisms. In many areas of the United States, Mycobacterium avium complex organisms are commonly isolated from the sputum of patients in whom a diagnosis of tuberculosis is highly probable, such as the elderly and patients with HIV infection. This finding has resulted in a marked decrease in the specificity and positive predictive value of the sputum smear, in some cases to as low as 50%. The gold standard for laboratory confirmation of tuberculosis is culture. Some patients may have a negative AFB smear, but a sufficient number of organisms may be present to produce a positive culture. Only 10 to 100 organisms are needed for a positive culture. As a result of the limitations of the AFB smear, a positive culture for Mycobacterium tuberculosis is necessary to definitively diagnose tuberculosis in patient HG and all patients, even if the AFB smear is positive. In addition, culture allows for genotyping and susceptibility testing of the isolate. Because M. tuberculosis grows slowly, i.e., once every 24 hours, it may take several weeks for the cultures to become positive. Broth-based culture systems such as BATEC, MGIT, MBBA, CT, SeptiCheck, and ESP, when combined with DNA probes, can result in positive cultures in 2 weeks or less for sputum smear-positive specimens and in 3 weeks or less for smear-negative specimens. Nucleic acid amplification, abbreviated as NAA, tests are available to enhance and expedite direct identification of Mycobacterium tuberculosis in clinical specimens independent of mycobacterial culture. These tests amplify the specific target sequences of nucleic acids in Mycobacterium tuberculosis that can be detected by a nucleic acid probe within 24 to 48 hours. 2 nucleic acid amplification tests are approved by the Food and Drug Administration (FDA) for use in the United States. The Enhanced Amplified Mycobacterium tuberculosis direct test is approved for detection of Mycobacterium tuberculosis in AFB smear-positive and smear-negative respiratory specimens. The sensitivity of this test is greater than 95% for patients with AFB-positive smears and 75% to 90% for patients with AFB-negative smears. The Amplicor Mycobacterium tuberculosis test is approved for detection of Mycobacterium tuberculosis in AFB smear-positive respiratory specimens. Sensitivity of the Amplicor test is greater than 95% for patients with AFB-positive smears and 60% to 70% for patients with AFB-negative smears. Specificity of the nucleic acid amplification tests is greater than 95% for both AFB smear-positive and smear-negative pulmonary specimens. Compared with AFB smears, additional benefits of nucleic acid amplification testing include the ability to rapidly confirm the presence of Mycobacterium tuberculosis in a majority of patients with AFB-negative smears and the positive predictive value of greater than 95% for AFB-positive specimens in settings where non-tuberculous mycobacteria are common. Nucleic acid amplification tests are cost-effective because they prioritize contact investigations, improve decision-making regarding respiratory isolation, and decrease unnecessary tuberculosis treatment. Current guidelines recommend nucleic acid amplification testing on at least one respiratory specimen from a patient with signs and symptoms of pulmonary tuberculosis for whom a diagnosis has not been established and for whom the test result would alter case management and infection control activities. If the nucleic acid amplification result and the AFB smear result are positive, the patient is presumed to have tuberculosis, and drug treatment should be initiated while awaiting culture results. If the nucleic acid amplification result is positive and the AFB smear result is negative, clinical judgment should be exercised regarding initiating drug therapy, and additional diagnostic testing may be needed. If the nucleic acid amplification result is negative and the AFB smear result is positive, a test for inhibitors should be performed and an additional specimen should be tested with nucleic acid amplification. Sputum specimens 3% to 7% might contain inhibitors that prevent or reduce amplification and cause false negative nucleic acid amplification results. If the nucleic acid amplification result and the AFB smear result are negative, clinical judgment is recommended in the decision to begin drug therapy because nucleic acid amplification tests lack the sensitivity in AFB smear negative specimens needed to exclude the diagnosis of tuberculosis. A negative response to 5-TU of PPD in patient HG would not exclude active infection with Mycobacterium tuberculosis. The PPD skin test has a reported false negative rate of 25% during the initial evaluation of persons with active tuberculosis. This high false negative rate is attributable to poor nutrition and general health, overwhelming acute illness, or immunosuppression. False negative results usually occur in persons who have only recently been infected or are anergic. Anergy, the decreased ability to respond to antigens, may be caused by severe debility, advanced age, immaturity in newborns, high fever, sarcoidosis, corticosteroids, immunosuppressive drugs, hematologic disease, HIV infections, overwhelming tuberculosis, recent viral infection, live virus vaccinations, and malnutrition. If anergy is suspected, control skin tests, that is in Candida, mumps, or trichophyton, may be placed in the contralateral arm. If the control test results are positive and the PPD test result is negative, infection with Mycobacterium tuberculosis is less likely. The Centers for Disease Control and Prevention (CDC) changed its recommendations regarding anergy skin testing in HIV-infected patients with a negative PPD. They cite problems with standardization and reproducibility, a low risk for TB associated with a diagnosis of anergy, and the lack of apparent benefit of therapy for latent tuberculosis infection in anergic HIV-infected patients. Therefore, the use of anergy testing in conjunction with PPD is no longer routinely recommended in this population or other patients who are immunocompromised. BCG, or Bacille calmette-guerin, is a live vaccine derived from an attenuated strain of Mycobacterium bovis, and it is used in many foreign countries with a high prevalence of tuberculosis to prevent the disease in persons who are tuberculin negative. Many different BCG vaccines are available worldwide, and they differ with respect to immunogenicity, efficacy, and reactogenicity. Additional factors, such as genetic variability in the vaccinated subjects, the nature of the mycobacteria endemic in different parts of the world, and the use of different doses and immunization schedules, may contribute to the varied degrees of protection provided by the vaccine. The protective effect derived from BCG vaccines in case control studies ranges from 0% to 80%. Two meta-analyses calculated estimates of the protective efficacy of BCG vaccination for preventing tuberculosis. Results from the first meta-analysis indicated a 75% to 86% protective effect against meningeal and miliary tuberculosis in children. In the second meta-analysis, the overall protective effect of BCG vaccines was approximately 50%. Vaccine efficacy was higher in studies in which persons were vaccinated during childhood in contrast with those vaccinated at older ages. Unfortunately, neither study could confirm vaccine efficacy for preventing pulmonary tuberculosis. Prior vaccination with BCG usually results in a false positive tuberculin skin test in patients who are not infected with Mycobacterium tuberculosis, but skin test reactivity does not correlate with protection against tuberculosis. There is no reliable method of distinguishing tuberculin reactions caused by BCG vaccination from those caused by natural mycobacterial infections. Therefore, it is prudent to consider positive reactions to 5-TU of PPD in BCG-vaccinated persons as indicating infection with Mycobacterium tuberculosis, especially among persons from countries with a high prevalence of tuberculosis. Even though patient HG received the BCG vaccine when he was a child, the results of the PPD skin test should still be considered positive, especially in light of his symptoms. In general, BCG vaccination is not recommended for routine prophylaxis in the United States because the risk of exposure to tuberculosis is relatively low. BCG vaccination should be considered only for very select persons who meet specific criteria and in consultation with a tuberculosis expert. BCG vaccination should only be considered for infants or children who are PPD negative and are continually exposed to a highly infectious, untreated patient with active tuberculosis, or a child who is continually exposed to a person with infectious pulmonary tuberculosis caused by Mycobacterium tuberculosis strains resistant to isoniazid and rifampin. BCG vaccination of healthcare workers should be considered on an individualized basis in settings in which a high prevalence of patients is infected with multidrug-resistant TB. Transmission of multidrug-resistant TB strains to healthcare workers and subsequent infection are likely, and comprehensive infection control precautions have been unsuccessful. BCG vaccination is contraindicated in pregnancy and in persons who are immunocompromised, e.g., HIV infection, or persons who are likely to become immunocompromised, e.g., organ transplantation. Adverse reactions to the BCG vaccine vary according to the type, dose, and age of the vaccine. Osteitis, prolonged ulceration at the vaccination site, leukoid reactions, regional suppurative lymphadenitis, disseminated BCG infection, and death have been reported. An interferon gamma release assay (IGRA) is preferred over the tuberculin skin test for persons who have received the BCG vaccine. 2 interferon gamma release assays are currently approved by the FDA as an aid for diagnosing both latent and active Mycobacterium tuberculosis infection, the QuantiFERON TB Gold test and the T-Spot TB test. These interferon gamma release assays assess response to synthetic peptides that represent specific proteins, early secretory antigenic target 6, that is ESAT6, and culture filtrate protein 10, abbreviated as CFP-10, that are present in all Mycobacterium tuberculosis strains. In sensitized patients, ESAT6 and CFP-10 are recognized by T cells and stimulate release of interferon gamma. The QuantiFERON TB Gold test measures the interferon gamma concentrations released using an enzyme-linked immunosorbent assay. The T-Spot tuberculosis test uses an enzyme-linked immunospot assay (ELI-SPOT) to detect increases in the number of cells that secrete interferon gamma. However, ESAT6 and CFP-10 are not present in BCG vaccine strains and most non-tuberculous mycobacteria, therefore, interferon gamma release assays have improved specificity in BCG-vaccinated persons compared with the tuberculin skin test. Results are available within 24 hours compared to 2 to 3 days for tuberculin skin testing. The CDC recommends HIV screening for all patients with tuberculosis as well as those persons suspected of having tuberculosis disease and contacts of patients with tuberculosis. Therefore, patient HG should be tested for HIV. HIV infection is the most important risk factor for progression of latent tuberculosis infection to active disease, and progression is more rapid in HIV-infected persons. Unlike other AIDS-related opportunistic infections, CD4 count is not a reliable predictor of increased risk of tuberculosis disease in HIV-infected persons. Tuberculosis may be the first manifestation of HIV infection because patients can have a relatively high CD4 count when tuberculosis disease develops. Next we will discuss the treatment of active disease. Let's begin with initial therapy. There are 4 basic regimens recommended for the treatment of adult patients with active tuberculosis caused by organisms that are known or presumed to be drug susceptible, shown in Table 68.2. Because patient HG has not been treated previously for TB, he should be started on isoniazid, rifampin, pyrazinamide, and ethambutol. However, he has been in close contact with persons with symptoms resembling tuberculosis who are from an area, Mexico, with a high prevalence of drug-resistant TB. Therefore, patient HG must be closely monitored for resolution of symptoms, results of repeated sputum smears, and culture and susceptibility results, regardless of the initial treatment regimen. Previous guidelines recommended the addition of ethambutol only if the local prevalence of isoniazid-resistant Mycobacterium tuberculosis is at least 4%. In the United States, 9.3% of Mycobacterium tuberculosis isolates recovered from patients with no previous history of tuberculosis were resistant to isoniazid in 2014. The prevalence of isoniazid resistance was higher in foreign-born persons, that is 10.2%, compared with US-born persons, that's 7.5%. In patients with a history of previous of TB, 18.9% of strains were resistant to isoniazid in 2014, with 24.7% resistance in foreign-born persons versus 4.4% resistance in US-born persons. Because of the relatively high likelihood of tuberculosis caused by isoniazid-resistant organisms, 4 drugs are necessary in the initial 8-week treatment phase.
The initial 4-drug regimen may be administered daily throughout the 8-week period, that is regimen 1, daily for the first 2 weeks and then twice weekly for 6 weeks, that is regimen 2, or thrice weekly throughout, that is regimen 3. Based on clinical experience, administration of drugs for 5 days per week is considered to be equivalent to 7 days per week administration, and either regimen 1 or the second of may be considered daily. However, 5-day-a-week administration should always be given by DOT. Drug dosages for these recommended regimens are listed in Table 68.3. Patient HG should be started on isoniazid 300 mg daily, rifampin 600 mg daily, pyrazinamide 1500 mg daily, and ethambutol 1200 mg daily. He should also receive pyridoxine 25 mg per day to minimize the risk for development of isoniazid-induced peripheral neuropathy.
Pause the video and carefully scrutinize Table 68.2 summarizing treatment regimens for pulmonary tuberculosis caused by drug-susceptible organisms before advancing to the next slide. Pause the video and carefully scrutinize Table 68.2 summarizing treatment regimens for pulmonary tuberculosis caused by drug-susceptible organisms before advancing to the next slide. Pause the video and carefully scrutinize Table 68.2 summarizing treatment regimens for pulmonary tuberculosis caused by drug-susceptible organisms before advancing to the next slide. Pause the video and carefully scrutinize Table 68.2 summarizing treatment regimens for pulmonary tuberculosis caused by drug-susceptible organisms before advancing to the next slide. Pause the video and carefully scrutinize Table 68.3 summarizing drugs used in the treatment of tuberculosis in adults and children before advancing to the next slide. Pause the video and carefully scrutinize Table 68.3 summarizing drugs used in the treatment of tuberculosis in adults and children before advancing to the next slide. Pause the video and carefully scrutinize Table 68.3 summarizing drugs used in the treatment of tuberculosis in adults and children before advancing to the next slide. Pause the video and carefully scrutinize Table 68.3 summarizing drugs used in the treatment of tuberculosis in adults and children before advancing to the next slide. Pause the video and carefully scrutinize Table 68.3 summarizing drugs used in the treatment of tuberculosis in adults and children before advancing to the next slide. Pause the video and carefully scrutinize Table 68.3 summarizing drugs used in the treatment of tuberculosis in adults and children before advancing to the next slide. Pause the video and carefully scrutinize Table 68.3 summarizing drugs used in the treatment of tuberculosis in adults and children before advancing to the next slide. Fixed-dose combinations of drugs have been advocated to improve adherence to the prescribed regimen, especially during the critical initial treatment phase. There are two fixed-dose combination preparations available in the United States: Rifamate, which contains isoniazid 150 mg and rifampin 300 mg, capsule, and Rifata, which contains isoniazid 50 mg, rifampin 120 mg, and pyrazinamide 300 mg per tablet. These formulations are a means of minimizing inadvertent monotherapy, especially when DOT is not possible, and they may decrease the risk of acquired drug resistance while reducing the number of capsules or tablets that must be ingested each day. Safety and efficacy of a 4-drug fixed-dose combination regimen was compared with each drug administered separately in patients with pulmonary tuberculosis. The combination tablet contained isoniazid 75 mg, rifampin 150 mg, pyrazinamide 400 mg, and ethambutol 275 mg, and 2 to 5 tablets were ingested per day based on body weight. The number of patients who were culture negative at 18 and 24 months was similar between the treatment groups, in addition to the number of treatment failures, relapses, and death. The 4-drug fixed-dose combination was non-inferior to each drug administered separately. It should be noted that there was no difference in outcomes based on HIV status, but less than 7% of the study subjects were HIV positive.
The high risk of transmission of Mycobacterium tuberculosis to other persons mandates that hospitalized persons with suspected or confirmed infectious tuberculosis be placed in respiratory isolation until they are determined not to have tuberculosis, they are discharged from the hospital, or they are confirmed to be non-infectious. Based on patient HG's subjective and objective findings, he should be placed in respiratory isolation. Patient HG's symptoms should improve within the first 4 weeks. He would be considered to be non-infectious when he is receiving effective drug therapy, is improving clinically, and has had negative results for 3 consecutive sputum AFB smears collected on different days. Patients who have responded clinically may be discharged to home despite positive smears if their household contacts have already been exposed and these contacts are not at increased risk of tuberculosis, e.g., infants, HIV-positive and immunosuppressed persons. In addition, patients discharged to home with positive smears must agree not to have contact with other susceptible persons.
We will now discuss fluoroquinolones as initial therapy. Interest in fluoroquinolones for the treatment of tuberculosis dates back more than 30 years, with a report describing the use of ofloxacin in 19 patients with chronic, drug-resistant tuberculosis disease. Several fluoroquinolones possess in vitro activity against M. tuberculosis, but moxifloxacin and gatafloxacin are 4 to 8-fold more potent than levofloxacin. Moxifloxacin was compared with ethambutol in the first 2 months of treatment in adults with smear-positive pulmonary tuberculosis. Patients were randomly assigned to receive moxifloxacin 400 mg daily or ethambutol based on body weight, and all patients received isoniazid, rifampin, and pyrazinamide. Patients receiving moxifloxacin were more likely to have negative sputum cultures at 4 weeks and 6 weeks, but the 2-month conversion rates were equal in each group. In another study, sputum culture conversion at 8 weeks was significantly greater in patients treated with moxifloxacin when compared with ethambutol, 80% versus 63%. Culture conversion rates were also significantly higher in the moxifloxacin group at weeks 1, 2, 3, and 4, and the median time to consistently negative cultures was 35.0 days in the moxifloxacin group and 48.5 days in the ethambutol group. Moxifloxacin has been compared with isoniazid during the intensive phase of treatment of pulmonary tuberculosis. Patients were randomly assigned to receive moxifloxacin 400 mg or isoniazid 300 mg daily, and all patients received rifampin, pyrazinamide, and ethambutol. After 8 weeks, negative sputum cultures were observed in 60.4% of the patients in the moxifloxacin group and 54.9% of patients in the isoniazid group, but this difference was not statistically significant.
Despite the reported efficacy of fluoroquinolones in the treatment of tuberculosis, clinicians must be cognizant of the potential development of resistance to this important drug class. Fluoroquinolone resistance in Mycobacterium tuberculosis has been described, occurring more frequently in multidrug resistant isolates. Fluoroquinolones are the most commonly prescribed antibiotic class in the United States, and outpatient use for infections other than tuberculosis could be a potential risk factor for tuberculosis resistance in a patient who becomes infected with Mycobacterium tuberculosis. In a study evaluating risk factors for fluoroquinolone-resistant Mycobacterium tuberculosis, investigators identified newly diagnosed patients with culture-confirmed tuberculosis in a Medicaid population. Of the 640 patients evaluated, 1/16, that is 18%, patients had fluoroquinolone exposure within the 12 months before diagnosis with tuberculosis, and 16, that is 2.5%, patients were infected with M. tuberculosis strains that were fluoroquinolone resistant. The study found that receipt of a fluoroquinolone for more than 10 days, occurring more than 60 days before diagnosis of tuberculosis, was associated with the highest risk for fluoroquinolone resistance. Therefore, judicious use of fluoroquinolones, especially in patients at risk for tuberculosis infection, is mandatory to maintain the utility of fluoroquinolones in the treatment of tuberculosis.
Next we will discuss susceptibility testing. Drug susceptibility testing is essential to ensure proper treatment of patients with active disease and should be performed on the initial isolate of Mycobacterium tuberculosis from all patients. Susceptibility testing should also be performed if cultures remain positive after 3 months of therapy or if negative cultures become positive after a period of time. Traditionally, susceptibility testing is performed by growing the organism on solid or in liquid media containing the drug. The agar proportion method allows for quantitation of the proportion of organisms that are resistant to a given drug, which is expressed as a percentage of the total organism population tested. The drug will not be useful for therapy if 1% or more of the total population are resistant to the drug. Unfortunately, susceptibility results may not be available for several weeks because of the slow growth of the organism and the need to isolate the pathogen before susceptibility testing can be performed. To expedite susceptibility reporting, molecular drug resistance tests have been developed to detect mutations in the chromosomal sequence encoding for resistance to a specific drug directly on clinical specimens without the need for growth on culture. For example, mutations in the R/P/OB gene block the activity of rifampin by preventing the drug from binding to RNA polymerase. Approximately 95% of rifampin-resistant Mycobacterium tuberculosis carry this mutation, and treatment failures have been associated with the presence of R/P/OB mutations. The molecular drug resistance test amplifies the target genetic sequence using polymerase chain reaction, and a second assay, such as DNA sequencing and hybridization assays, is used to determine whether the sequence contains a mutation associated with drug resistance. If a mutation is detected, the organism is considered to be drug-resistant, but the organism is presumed to be drug-susceptible if a mutation is not detected. Molecular tests can reliably detect the presence of known mutations within 1 to 2 days, which may result in earlier initiation of effective therapy, shorter durations of infectivity, and reduced spread of tuberculosis. However, these molecular drug resistance tests can only detect a specific set of known mutations and cannot identify novel mutations conferring resistance. Therefore, traditional susceptibility testing continues to play an important role in confirming results of molecular testing. Kits for detecting mutations associated with rifampin resistance include genotype MTBDR+ and INO-LiPA-RIF-TB. Compared with culture-based drug resistance tests, the sensitivity and specificity of the MTBDR+ line probe assay were 98% and 99%, respectively, for detecting rifampin resistance in isolates or directly from clinical specimens. The sensitivity of the INO-LiPA-RIF-TB assay ranged from 80% to 100% and the specificity was 100% for detecting rifampin resistance directly from clinical specimens. Molecular beacons are hybridization probes that use fluorescent-labeled, hairpin-shaped DNA probes with a fluorophore adjacent to a molecule that prevents fluorescence. Using a real-time polymerase chain reaction assay, fluorescence occurs if the amplified PCR products have the wild-type gene sequence, but fluorescence is not detected if mutations are present in the target sequence. These tests have high sensitivity 96% to 97% and specificity 99% to 100% for rifampin resistance in clinical specimens. Molecular drug resistance tests for other antitubercular drugs are not fully developed compared with tests for rifampin resistance. For detecting mutations associated with isoniazid resistance, the specificity of the MTBDR+ assay was 100%, but the sensitivity ranged from 57% to 100%, called sensitivity 85%. However, rifampin resistance is a reliable surrogate for multidrug-resistant TB in the United States because isolated rifampin resistance is uncommon. The Expert MTB-RIF assay is an automated molecular-based test that uses nested real-time polymerase chain reaction, allowing for simultaneous detection of Mycobacterium tuberculosis and rifampin resistance. The test is approved for diagnostic testing of raw sputum samples, and results are available within 2 hours. Sensitivity is 95% to 98.2% in AFB culture or smear-positive specimens, but performance is correlated with bacterial load because sensitivity is only 55% to 72.5% in smear-negative specimens. Sensitivity is also lower in patients with HIV infection. Specificity was 94% to 99.2% in patients with negative cultures. The Expert MTB-RIF test also correctly identified 98.1% of patients with rifampin-susceptible bacilli and 97.6% of patients with rifampin-resistant bacilli. Yes, each case of active tuberculosis disease must be reported to the local, state, or both public health departments. This not only results in optimal therapy by monitoring adherence to therapy, but it also ensures that contact and source case investigations will be performed. All individuals who have been in close contact to patient HG should be evaluated for latent tuberculosis infection or active disease. Considering their close contact to patient HG and his coworkers, his family members should be evaluated. Reporting of cases also permits record keeping and surveillance to determine whether public health tuberculosis control efforts are achieving the goal of preventing the spread of tuberculosis.
We will now look at continuation therapy of tuberculosis. Let's look at the regimens. Successful treatment of uncomplicated tuberculosis can be achieved in 6 months, that is 26 weeks, if isoniazid, rifampin, pyrazinamide, and ethambutol are used for the first 2 months, that is 8 weeks, and if patient adherence to the regimen and the organism's susceptibility can be assured. Therefore, after 8 weeks of DOT with isoniazid, rifampin, pyrazinamide, and ethambutol, HG's regimen may be streamlined to isoniazid and rifampin daily, 5 days or 7 days per week, or 2 to 3 times per week under continued DOT for an additional 18 weeks, as shown in Table 68-2. Because patient HG is HIV negative and cavitary lesions were not present on his chest radiograph, he may also be a candidate for once-weekly administration of isoniazid and rifampin, as long as his sputum AFB smear is negative after completing the initial 8 weeks of therapy. The effectiveness of a primarily twice-weekly treatment regimen has been demonstrated in both pulmonary and extrapulmonary tuberculosis. The regimen consisted of isoniazid 300 mg, rifampin 600 mg, pyrazinamide 1.5 to 2.5 g, and streptomycin 750 to 1000 mg intramuscularly daily for 2 weeks, followed by the same drugs twice weekly for an additional 6 weeks. The regimen was then reduced to isoniazid and rifampin twice weekly for the remaining 16 weeks, that is 4 months. At 3 months, 75% of patients had negative sputum cultures, and all patients were culture negative at 20 weeks. Relapse occurred in 2 patients and only minor adverse effects were reported. Another important feature is that this regimen is highly cost-effective. Among the 6 and 9-month regimens, it is the second lowest in cost, primarily because of the least number of patient healthcare worker encounters, 62 directly observed doses.
If pyrazinamide cannot be included in the initial regimen, therapy should be initiated with isoniazid, rifampin, and ethambutol for the first 8 weeks. Therapy should be continued with isoniazid and rifampin for 31 weeks given either daily or twice weekly. If drugs other than isoniazid and rifampin are used in the initial phase, treatment must be continued for 18 to 24 months. Twice-weekly administration of isoniazid, dosed at 900 mg, and rifampin, dosed at 600 mg, is recommended for patient HG because this approach requires fewer doses and should result in substantial cost savings. In addition, the relapse rates for the twice and thrice-weekly isoniazid and rifampin continuation regimens are significantly lower than the once-weekly regimen of isoniazid and rifampin 600 mg. 5 characteristics were associated with increased relapse risk in the isoniazid and rifampin group: sputum culture positive at 2 months, cavitation on chest radiograph, underweight, bilateral pulmonary involvement, non-Hispanic Caucasian race. A potential explanation for these results is the high protein binding of rifampin, 98%. A study evaluated the safety and tolerability of rifampin 600, 900, and 1,200 mg once weekly, with isoniazid 15 mg per kilogram in 150 HIV-negative patients. A trend toward more adverse events was observed in the 1,200 mg treatment arm, with a p-value equal to 0.051, but the 900 mg dose was well tolerated. However, relapse rates for the higher dose weekly rifampin regimens with isoniazid are unknown. A subsequent study demonstrated that low plasma concentrations of isoniazid were associated with failure or relapse with once-weekly isoniazid and rifampin. Two patients who relapsed with Mycobacterium tuberculosis monoresistant to rifamycin had very low isoniazid concentrations. Rapid acetylation status was a risk factor in those patients who failed or relapsed. Rifamycin pharmacokinetics did not influence patient outcomes, however. Treatment with isoniazid and rifampin should be continued for a minimum total duration of 26 weeks. A full course of therapy can be more accurately determined by the total number of doses ingested, not solely by the duration of therapy. Thus, 26 weeks is the minimum duration of treatment and accurately indicates the amount of time the drugs are given only if there are no interruptions in drug administration. Pyridoxine 10 to 25 mg per day should be continued throughout the treatment period. If patient Hg is symptomatic, or smear or culture is positive after 3 months of therapy, he should be re-evaluated for possible non-adherence with his therapy, malabsorption of the drugs, or infection with drug-resistant organisms. Evaluation should include a second culture and a second susceptibility test, consideration of DOT, if not already instituted, and consultation with experts in the treatment of tuberculosis. Treatment of active tuberculosis for 26 weeks is a challenge to ensure patients adhere to the prescribed regimen for the total duration of therapy. Shorter course treatment regimens, if efficacious, could be helpful in improving adherence rates, decreasing treatment costs, and reducing adverse events. 3 published studies evaluated the treatment of drug-susceptible tuberculosis for a total duration of 4 months using modified regimens that included a fluoroquinolone, that is moxifloxacin or gatafloxacin. The control regimen was the same in each study and consisted of 8 weeks of isoniazid, rifampin, pyrazinamide, and ethambutol followed by isoniazid and rifampin for 18 weeks. In all 3 studies, unfavorable outcomes and culture-confirmed relapse or recurrence were more common in patients receiving the short-course regimens, therefore, non-inferiority was not demonstrated for any of the 4-month regimens. Based on these studies, patient Hg should receive 26 weeks of therapy, and every effort should be made to ensure adherence to the treatment regimen. Next we will discuss directly observed therapy. Directly observed therapy, abbreviated as DOT, is the practice of a healthcare provider or other responsible person observing as the patient ingests and swallows the tuberculosis medications. Directly observed therapy is the preferred core management strategy for all patients with tuberculosis. The purpose of directly observed therapy is to ensure adherence to tuberculosis therapy. Directly observed therapy not only ensures completion of therapy, but it may also reduce the risk of developing drug resistance. Improving these 2 factors, it also reduces the risk of transmission of tuberculosis to the community. Directly observed therapy can be administered with daily or twice and thrice weekly regimens. It can be administered to patients in the office or clinic setting, or it can be given at the patient's home, school, or work. Often, enablers or incentives, such as food, clothing, or transportation, are used to improve adherence to directly observed therapy. A comprehensive review of directly observed therapy-related articles found that the completion rate of tuberculosis therapy exceeds 90% when directly observed therapy is used along with enablers. A study found that culture-positive patients treated for active pulmonary tuberculosis with directly observed therapy had significantly higher cure rates, that is 97.8% versus 88.6%, with a p-value less than 0.002, and lower tuberculosis-related mortality 0% versus 5.5%, with a p-value equal to 0.002, compared with patients treated using self-administered therapy. Although directly observed therapy is recommended for all patients, public health departments may not be able to provide directly observed therapy. for all patients because of the associated costs. The initial cost of directly observed therapy is greater than self-administered therapy. However, when costs of relapse and failure are included in a cost-effectiveness analysis, directly observed therapy is significantly less expensive than self-administered therapy. When drug resistance develops, in those instances in which directly observed therapy is not used, the cost of salvage therapy increases to $180,000 per patient. It is, therefore, widely accepted that patients with tuberculosis should receive directly observed therapy. Next we will discuss multiple drug therapy of tuberculosis. The key to treating active tuberculosis disease is multiple drug therapy for a period sufficient to kill the organisms and to prevent development of resistant strains of Mycobacterium tuberculosis. Most cavitary lesions contain a concentration of 109 to 1012 organisms, and the frequency of mutations that confer resistance to a single drug is approximately 10 to 6 for isoniazid and streptomycin, 10 to 8 for rifampin, and 10 to 5 for ethambutol. Considering the inoculum of organisms involved, patients with active tuberculosis disease likely harbor organisms with random mutations that confer drug resistance to a given drug. If a single drug is given, it would reduce the number of drug-susceptible organisms but allow the drug-resistant organisms to replicate. By using multiple drug therapy, the likelihood of encountering organisms with mutations to multiple drugs is reduced. For example, the frequency of concurrent mutations to isoniazid and rifampin would be 10 to 14, 10 to 6 for isoniazid and 10 to 8 for rifampin, making simultaneous resistance to both drugs an unlikely event in an untreated patient. Therefore, monotherapy should never be used in the treatment of active tuberculosis disease. Multiple drug therapy also serves to sterilize the sputum and lesions as quickly as possible. The drugs available for the treatment of tuberculosis vary in their ability to accomplish this task. Drugs effective against tubercle bacilli can be divided into first-line and second-line agents, shown in Table 68.3. The foundation of treatment should be with first-line agents, such as isoniazid, rifampin, pyrazinamide, and ethambutol. Of the various agents, isoniazid has the most bactericidal activity versus rapidly multiplying Mycobacterium tuberculosis during the initial phase of therapy, early bactericidal activity, followed by ethambutol, rifampin, and streptomycin. Drugs that have potent early bactericidal activity more rapidly decrease the infectiousness of the patient and reduce the likelihood of developing resistance. Pyrazinamide has weak early bactericidal activity during the first 2 weeks of therapy and is less effective at preventing emergence of drug resistance than isoniazid, rifampin, and ethambutol. Therefore, pyrazinamide should not be combined with only one other agent when treating active tuberculosis disease. Rifampin also has activity against intracellular organisms that are usually dormant but undergo periods of active growth. This ability to penetrate and destroy the persistent intracellular organisms makes rifampin extremely valuable in short-course chemotherapy regimens. Pyrazinamide is most effective against tubercle bacilli in the acidic environment within the macrophage or areas of tissue necrosis. In addition, it is most effective in sterilizing lesions when used in the first 2 months of treatment, but it does not offer substantial sterilizing activity after 2 months. Pyrazinamide should be considered an essential component of short-course regimens. Ethambutol is bacteriostatic at low doses, but bactericidal at higher doses. It is moderately effective against the fast-growing bacilli. It has little sterilizing activity and is primarily used to prevent the emergence of drug-resistant organisms. Streptomycin is bactericidal against rapidly multiplying extracellular organisms and is effective when given daily for 2 months followed by twice or thrice weekly administration thereafter. In the past, streptomycin was administered by intramuscular injection, but these intramuscular injections were painful. Therefore, although it is not labeled for intravenous use, streptomycin may be given in 50 to 100 ml of 5% dextrose in water or normal saline and infused for 30 to 60 minutes. Streptomycin can cause ototoxicity and nephrotoxicity, as with other aminoglycosides. Other drugs used in the treatment of tuberculosis, including bedaquiline, capreomycin, amikacin, cycloserine, ethionamide, and para-aminosalicylic acid, are usually reserved for cases involving drug-resistant organisms, treatment failures, drug toxicity, or patient intolerance to the other agents. The use is discussed later in the chapter. Let's now look at monitoring drug therapy. Patient HG should be questioned about the occurrence of adverse reactions associated with his therapy, shown in Table 68.3. Specifically, he should be asked about anorexia, nausea, vomiting, or abdominal pain, which may be an indication of possible hepatitis secondary to isoniazid, rifampin, or pyrazinamide. He should be questioned about numbness and tingling in his extremities. However, isoniazid-induced peripheral neuropathy should not be a problem in patient HG because he is also taking pyridoxine, which should prevent this adverse effect. Patient HG also should be examined for, and questioned about, petechiae or bruises, because thrombocytopenia occurs occasionally with intermittent rifampin therapy. This effect purportedly occurs more frequently with intermittent rifampin therapy, but it is rare at the currently recommended intermittent rifampin dose of 10 mg per kilogram per day, approximately 600 mg. In a study comparing 6 versus 9-month antituberculosis therapies of mostly isoniazid and rifampin, the incidence of side effects was similar between the two groups. Adverse effects occurred in 7.7% of patients in the 6-month arm compared with 6.4% in the 9-month arm, a difference that was not statistically significant. Hepatic abnormalities occurred in 1.6% of patients in the 6-month regimen, a non-significant difference from patients in the 9-month regimens, that is 1.2%. Hematologic events were rare at 0.2% and 0.0% in the 6 and 9-month groups, respectively. Other reported effects, gastrointestinal problems, rash, and arthralgias were minor and infrequent in both regimens. Let's now discuss objective signs of tuberculosis. A pretreatment complete blood count, platelet count, blood urea nitrogen, hepatic enzymes, that is serum aminotransferases, bilirubin, and serum uric acid should be evaluated. Baseline visual examination should also be considered for patients receiving ethambutol. These tests are performed to detect any abnormality that may complicate or necessitate modification of the prescribed regimen. These tests should be repeated if the patient experiences any evidence of drug toxicity or has abnormalities at baseline. Patient HG is 35 years of age and at increased risk for development of drug-induced hepatotoxicity. Isoniazid can cause asymptomatic increases in serum transaminases as well as overt hepatitis. Pyrazinamide has also been associated with hepatotoxicity, but the incidence is less common at doses of 25 mg per kilogram per day or less. Transient asymptomatic hyperbilirubinemia and cholestatic hepatitis can occur in patients receiving rifampin. Therefore, it is important that patient HG be educated about possible symptoms of hepatotoxicity, primarily nausea, vomiting, abdominal pain, anorexia, and jaundice. Monthly serum liver function tests, abbreviated as LFTs, are no longer recommended because they are costly, and transient, asymptomatic elevations in liver function tests may occur, which could result in unnecessary discontinuation of optimal therapy. The CDC recommends that medical personnel question patients about symptoms once monthly. Sputum cultures and smears for AFB should be ordered every 2 to 4 weeks initially and then monthly after the sputum cultures become negative. With appropriate therapy, sputum cultures should become negative in more than 85% of patients after 2 months. Radiologic examination, that is chest radiographs, is not as important as sputum examination, but it may be useful at the completion of therapy to serve as a comparison for any future films. Patients who are culture positive at 2 months need to be carefully re-examined. Drug susceptibility testing should be performed to rule out acquired drug resistance, and special attention should be given to drug adherence, i.e., directly observed therapy should be used. If drug resistance is demonstrated, the regimen should be modified as needed. Sputum cultures should also be obtained monthly until negativity is achieved. As was the case for patient Hg, weight loss and nutritional depletion are common in patients with active tuberculosis disease. In a large tuberculosis treatment study, 7.1% of patients experienced relapse, with relapse greatest in patients who were underweight at diagnosis or with a body mass index less than 18.5 kg per meter squared. In those patients underweight at diagnosis, defined as equal to or more than 10% below ideal body weight, weight gain of 5% or less between diagnosis and completion of 2 months of therapy was independently associated with relapse. In addition, the relapse rate was 50.5% in underweight patients with a cavitary lesion on chest radiograph, positive sputum cultures after 2 months of therapy, and a 5% or less weight gain in the first 2 months of therapy. Therefore, it may be prudent to monitor patient Hg's body weight during the initial 2 months of therapy, and he may need to receive more intensive therapy or a longer duration of therapy. Routine follow-up usually is not required after the successful completion of chemotherapy with isoniazid and rifampin. It may be prudent, however, to re-examine the patient 6 months after completion of therapy or at the first sign of any symptoms suggestive of active tuberculosis. This is especially important in patients who were slow to respond to therapy or who have significant radiologic findings at completion of therapy. These recommendations are only for those patients with organisms fully susceptible to the medications being used. Patients who are culture negative but have radiographic abnormalities consistent with TB should have an induced sputum or bronchoscopy performed to establish a microbiologic diagnosis and monitored radiographically. Patients with extrapulmonary tuberculosis should be evaluated according to the site of involvement. We will now discuss treatment failure. No, adding a single drug to a failing regimen is the most common and devastating prescribing error in tuberculosis therapy. This practice is essentially monotherapy because the assumption is that the organisms are resistant to the medications currently being used. Resistance to the new drug will eventually develop, further reducing the patient's chance of cure. At least 2, and preferably 3, new drugs to which susceptibility can be inferred should be added to lessen the probability of further acquired drug resistance. Empiric retreatment regimens may include a fluoroquinolone, bedaquiline, an injectable agent e.g., streptomycin, amikacin, or capreomycin, and an additional oral agent e.g., para-aminosalicylic acid, cycloserine, or ethionamide. New drug susceptibility testing should be performed and treatment adjusted accordingly. Next we will discuss the treatment of latent tuberculosis. Because patient JG is a household contact of a person with active tuberculosis disease and has a positive tuberculin skin test, she is at great risk of developing active disease. During the first year after infection from the index case, a household contact's risk of developing active disease is 2% to 4%, and contacts with a positive tuberculin skin test are at the greatest risk. As with active disease, the tuberculin skin test is usually performed to detect the presence of latent tuberculosis infection. However, for contact investigation, studies have demonstrated that interferon gamma release assays are a more accurate indicator of the presence of latent tuberculosis infection than tuberculin skin testing. Therefore, many health departments in the United States have adopted interferon gamma release assays as screening tests for contact investigations. The majority of people with a negative interferon gamma release assays after exposure to a person with active tuberculosis disease do not have tuberculosis infection. However, the immune reaction to tuberculosis can take several weeks to develop, so the interferon gamma release assays should be repeated 8 to 12 weeks after the last exposure to rule out infection. Tuberculin skin testing is preferred for screening children younger than 5 years old. Treatment of latent tuberculosis infection is effective in preventing active tuberculosis disease in patients with a positive tuberculin skin test or interferon gamma release assays result and in those at risk for reactivation of active tuberculosis. Therefore, it is strongly recommended. Treatment decreases the population of tubercle bacilli and reduces future morbidity from tuberculosis in the groups at high risk for developing active disease. Because patient JG is infected with Mycobacterium tuberculosis but does not currently have active tuberculosis disease, she should be treated for latent tuberculosis infection. There are 4 approved regimens for the treatment of latent tuberculosis. Isoniazid monotherapy prevents active tuberculosis in 90% of patients who complete a 9-month regimen compared to 60% to 80% of patients who complete a 6-month regimen. Therefore, isoniazid 300 mg daily or 900 mg twice weekly for 9 months is preferred. The twice-weekly regimen should be administered by DOT to ensure patient adherence. A 6-month regimen is an acceptable alternative in patients who cannot complete 9 months of therapy. The benefits of treating latent tuberculosis infection outweigh the risks of isoniazid-induced hepatitis because all persons infected with tuberculosis are at risk for developing active disease throughout their lifetime. All patients receiving isoniazid should receive pyridoxine 25 mg per day to minimize the risk of peripheral neuropathy. Unfortunately, patient adherence to these isoniazid regimens is very poor. In a population of patients beginning isoniazid treatment for latent tuberculosis, only 64% of patients completed at least 6 months of therapy. Younger age, Hispanic ethnicity, and non-U.S. country of birth were associated with greater likelihood of completing therapy. Lower completion rates were associated with homelessness, excess alcohol intake, and experiencing an adverse event. In another study, 52.7% of patients receiving treatment for latent tuberculosis infection failed to complete the prescribed course of therapy. More than 93% of these patients were receiving isoniazid. Risk factors for failing to complete therapy included receipt of a 9-month isoniazid regimen, residence in a congregate setting, nursing home, shelter, jail, injection drug use, and employment at a healthcare facility. In addition, this study reported that employees at healthcare facilities were more likely to decline treatment for latent tuberculosis infection. Because of concerns for isoniazid toxicity and abysmal adherence rates, shorter rifampin-based regimens may be utilized. Daily isoniazid plus rifampin for 3 months and daily rifampin monotherapy for 4 months are acceptable alternatives to isoniazid therapy. For the patients randomly assigned to receive daily rifampin for 4 months, 91% took 80% of the doses, and 86% took more than 90% of the doses at 20 weeks. For the patients randomly assigned to receive daily isoniazid for 9 months, 76% took 80% of the doses, and only 62% took more than 90% of the doses at 43 weeks. Discontinuation of therapy due to an adverse events was more common in the isoniazid group, that is 14%, versus the rifampin group, that is 3%. Another study reported significantly fewer grade 3 to 4 adverse events and hepatitis and significantly higher treatment completion rates with 4 months of rifampin compared with 9 months of isoniazid. Rifampin for 4 months is an effective, safe, and cost-effective strategy to consider when treating latent tuberculosis infection in selected populations of patients. An attractive alternative for the treatment of latent tuberculosis infection is the combination of isoniazid and rifampin administered once weekly for 12 weeks. In one study, patients received either isoniazid 15 to 25 mg per kilogram, maximal dose 900 mg, plus rifampin 900 mg, with adjustments for patients weighing less than 50 kg once weekly for 12 weeks by directly observed therapy, or isoniazid 5 mg per kilogram, maximal dose 300 mg, once daily for 9 months. Completion of therapy was significantly higher in the isoniazid, rifampin group 82% versus 69%, with a p-value less than 0.001. Overall, tuberculosis developed in 7 of 3,986 patients receiving isoniazid, rifampin, and 15 of 3,745 patients receiving isoniazid, hazard ratio 0.38 for the combination, with a 95% confidence interval of 0.15 to 0.99, with a p-value equal to 0.05. Hepatotoxicity was higher in the isoniazid group, 2.7% versus 0.4%, with a p-value less than 0.001, whereas hypersensitivity reactions were higher in the combination group, 3.8% versus 0.5%, with a p-value less than 0.001.
Permanent drug discontinuation for any reason was higher in the isoniazid group, 31.0% versus 17.9%, with a p-value less than 0.001, but permanent drug discontinuation due to an adverse event was higher in the combination group, 4.9% versus 3.7%, with a p-value equal to 0.009. The combination is recommended as an equal alternative to daily isoniazid for 9 months in patient 12 years or older with a greater risk of developing active tuberculosis disease. These patients include those with recent exposure to a person with active tuberculosis, conversion of the tuberculin skin test or interferon gamma release assay from negative to positive, or radiographic evidence of healed pulmonary tuberculosis. Isoniazid, rifampin may also be considered in patients unlikely to complete 9 months of isoniazid or in a setting where the combination offers practical advantages, e.g., correctional facilities, homeless shelters. The combination is not recommended in women who are pregnant or who expect to become pregnant during treatment. Patient JG should be placed on isoniazid 300 mg per day or 900 mg twice weekly for at least 6 months and preferably up to 9 months, rifampin 600 mg for 4 months, or isoniazid 900 mg plus rifampin 900 mg weekly for 12 weeks. She should be educated and questioned frequently about the clinical symptoms of hepatitis, such as GI complaints. Pretreatment serum aminotransferases and bilirubin should be assessed to rule out pre-existing liver disease. The American Thoracic Society and the CDC do not recommend routine monitoring of LFTs unless symptoms suggest hepatotoxicity.
We will now talk about adverse drug events. Let's begin with isoniazid hepatotoxicity. Approximately 10% to 20% of patients treated with isoniazid alone for latent tuberculosis infection will develop elevated serum aminotransferases, which are generally transient and asymptomatic. Most patients with mild, subclinical hepatic damage do not progress to overt hepatitis and recover completely even while continuing isoniazid. In contrast, continuation of isoniazid in patients with symptoms of hepatitis increases the risk of mortality compared with immediate discontinuation. The risk of death from tuberculosis, however, is estimated to be 11 times higher than the risk of death from isoniazid hepatotoxicity. Isoniazid-induced hepatotoxicity generally occurs within weeks to months of initiating therapy. 60% of cases occur in the first 3 months and 80% occur in the first 6 months. Constitutional symptoms may be seen early and may last from days to months. Nausea, vomiting, and abdominal pain are seen in 50% to 75% of patients with severe hepatotoxicity. Jaundice, dark urine, and clay-colored stools may also be seen. Recovery may take weeks after discontinuing isoniazid therapy. The development of isoniazid hepatotoxicity has been linked to several factors, including acetylator phenotype, age, daily alcohol consumption, and concurrent rifampin use. Additionally, women may be at higher risk of death, especially during the postpartum period. The mechanisms responsible for isoniazid hepatotoxicity remain unclear. Previously, it was thought that rapid acetylators had a greater risk for isoniazid hepatotoxicity than slow acetylators. Rapid acetylators of isoniazid form monoacetylhydrazine, a compound that can cause liver damage, more rapidly than slow acetylators. Rapid acetylators, however, would eliminate monoacetylhydrazine at a faster rate, and this should equalize the risk of toxicity between slow and fast acetylators. One study demonstrated a different incidence of hepatitis between Asian men and women. Because both groups were fast acetylators, this study suggests that hepatitis is associated with factors other than acetylator phenotype. Some evidence supports the theory that isoniazid-induced hepatitis is a hypersensitivity reaction. However, many patients tolerate isoniazid on re-challenge, discounting this theory. Age and concurrent daily alcohol ingestion are the most consistent risk factors for isoniazid hepatitis. Progressive liver damage is rare in persons younger than 20 years of age. It occurs in approximately 0.3% of persons between the ages of 20 and 34 years, 1.2% of those between the ages of 35 and 49 years, and 2.3% of persons older than 50 years of age. One prospective cohort study, however, demonstrated a low incidence of isoniazid hepatitis. Of 11,141 patients receiving isoniazid alone for the treatment of latent tuberculosis infection, only 11, that is 0.1% of those starting and 0.15% of those completing therapy, developed clinical hepatitis. Previous studies suggested a higher incidence of clinical hepatitis in patients receiving isoniazid alone, and a meta-analysis of 6 studies estimated the rate to be 0.6%. However, severe hepatotoxicity may occur with isoniazid treatment of latent tuberculosis infection. The CDC reported 17 severe hepatic adverse events with isoniazid in 15 adults and 2 children, ages 11 and 14 years. 5 patients, including 1 child, underwent liver transplantation, and 5 adults died, including 1 liver transplant patient. High-risk patients should be followed with routine monitoring of LFTs. These patients include those who consume alcohol daily, persons older than 35 years of age, those taking other hepatotoxic drugs, those with pre-existing liver disease, intravenous drug users, Black and Hispanic women, and all postpartum women. In these high-risk patients, isoniazid should be discontinued if the AST level exceeds 3 to 5 times the upper limit of the normal value, 66, because patient JG is experiencing nausea, vomiting, and abdominal pain and her AST is greater than 3 times the upper range of the normal value. Isoniazid should be discontinued temporarily until the AST returns to normal. At that time, isoniazid should be resumed, and her LFTs rechecked. If the AST increases again, the drug should be discontinued, and patient JG should be followed frequently for development of active tuberculosis. 5 patients, including 1 child, underwent liver transplantation, and 5 adults died, including 1 liver transplant patient. High-risk patients should be followed with routine monitoring of LFTs. These patients include those who consume alcohol daily, persons older than 35 years of age, those taking other hepatotoxic drugs, those with pre-existing liver disease, intravenous drug users, Black and Hispanic women, and all postpartum women. In these high-risk patients, isoniazid should be discontinued if the AST level exceeds 3 to 5 times the upper limit of the normal value, 66, because patient JG is experiencing nausea, vomiting, and abdominal pain and her AST is greater than 3 times the upper range of the normal value. Isoniazid should be discontinued temporarily until the AST returns to normal. At that time, isoniazid should be resumed, and her LFTs rechecked. If the AST increases again, the drug should be discontinued, and patient JG should be followed frequently for development of active tuberculosis. Next we will discuss peripheral neuropathy. Although uncommon at the recommended daily and intermittent doses, isoniazid can cause a peripheral neuropathy by interfering with pyridoxine, vitamin B6 metabolism. As many as 20% of patients may experience this problem with isoniazid doses greater than 6 mg per kilogram per day. Numbness or tingling in the feet or hands is the most common neuropathic symptom. In patients with medical conditions in which neuropathy is common, including diabetes mellitus, alcoholism, HIV infection, malnutrition, and renal failure, supplemental pyridoxine 25 mg per day should be given with isoniazid. Women who are pregnant or breastfeeding and persons with seizure disorders should also receive supplemental pyridoxine with isoniazid. We will now talk about allergic and other reactions. Allergic reactions consisting of arthralgias, skin rash, swelling of the tongue, and fever have also been reported. Isoniazid has been associated with arthritic symptoms and systemic lupus erythematosus. Approximately 20% of patients receiving isoniazid develop anti-nuclear antibodies. Other less common reactions reported with isoniazid are dry mouth, epigastric distress, CNS stimulation and depression, psychoses, hemolytic anemia, pyridoxine-responsive anemia, and agranulocytosis. Next we will move on to drug interactions. Isoniazid is a relatively potent inhibitor of several cytochrome P450 isoenzymes CYP2C9, CYP2C19, CYP2E1, but has minimal effects on CYP3A. Isoniazid inhibits the hepatic metabolism of phenytoin and carbamazepine, resulting in increased plasma concentrations of these drugs. Patients receiving either of these two drugs with isoniazid should be observed for signs of phenytoin or carbamazepine toxicity, such as nystagmus, ataxia, headache, nausea, or drowsiness. Plasma phenytoin and carbamazepine concentrations should be monitored periodically so that the doses can be adjusted if necessary. Carbamazepine also may induce isoniazid hepatitis by inducing its metabolism to toxic metabolites. In addition, isoniazid inhibits the metabolism of diazepam and triazolam. It is important to note that rifampin has the exact opposite effect on hepatic metabolism. Rifampin is a stronger inducer than isoniazid is an inhibitor, as documented by the fact that isoniazid-rifampin combination therapy induces the metabolism of diazepam, phenytoin, and other agents metabolized by the cytochrome P450 system. Next we will look at rifampin. Let's begin with flu-like syndrome. A flu-like syndrome has been reported in 1% of patients receiving intermittent rifampin administration. This syndrome is rarely seen with usual doses of 600 mg twice weekly, but the incidence increases with twice-weekly doses greater than 900 mg. The incidence also increases if the dosing interval is increased to 1 week or longer. Unless the symptoms are severe, discontinuation of the drug is unnecessary. Because patient CM is receiving rifampin 900 mg twice weekly, her dose should be reduced to 600 mg and administered daily until the symptoms subside. Temporary administration of a nonsteroidal anti-inflammatory drug has been used to alleviate the flu-like symptoms. Twice-weekly therapy may then be resumed as long as the dose of rifampin dose does not exceed 600 mg. Next we will talk about hepatotoxicity. Rifampin, and even rifapentine, are associated with a less than 1% rate of hepatotoxicity. Therefore, the risk of drug-induced hepatotoxicity is greater with isoniazid than with rifampin. On occasion, rifampin can cause hepatocellular injury and potentiate hepatotoxicity of other antituberculosis drugs. Although elevations of liver enzymes may be seen, rifampin is more likely to produce cholestasis, as manifested by increases in alkaline phosphatase and hyperbilirubinemia without hepatocellular injury. Elevations of all liver function tests may be seen transiently during the first month of rifampin therapy, but they are usually benign. Next we will discuss thrombocytopenia. Thrombocytopenia is more frequently associated with intermittent or interrupted rifampin administration, likely caused by production of immunoglobulin G and immunoglobulin M antibodies to rifampin. These antibodies likely fix complement onto platelets, resulting in platelet destruction. Hypothetically, intermittent or interrupted rifampin therapy results in increased antibody production. Once thrombocytopenia occurs with rifampin, its subsequent use is contraindicated because the problem will likely recur. And now we will move on to miscellaneous reactions. In addition to the side effects associated with high-dose, intermittent therapy, 3% to 4% of patients taking normal doses of rifampin may experience adverse reactions. The most common of these are nausea, vomiting, fever, and rash. Other reactions to rifampin include the hepatorenal syndrome, hemolysis, leukopenia, anemia, and arthralgias as part of a suspected drug-induced lupus syndrome. Development of these latter reactions requires discontinuation of the drug. Let's now move on to acute renal failure. Acute renal failure has been reported rarely with rifampin. This hypersensitivity reaction may occur with both intermittent and daily administration and may last as long as 12 months. Rifampin should be discontinued, and other drugs, e.g., pyrazinamide and ethambutol, should be given. Doses of ethambutol and pyrazinamide should be adjusted for renal dysfunction, if necessary. Both rifampin and isoniazid may, however, be given in normal dosages to patients with pre-existing renal failure. We will now look at the discoloration of body fluids. Another important characteristic of rifampin relates to its chemical makeup. It is an orange-red crystalline powder that is distributed widely in body fluids. As a result, it can discolor saliva, tears, urine, sweat, and cerebrospinal fluid. Patients using rifampin should be warned of this effect and cautioned not to use soft contact lenses because of possible discoloration. This effect may also be used to monitor adherence to rifampin therapy. Let's briefly discuss drug interactions. Rifampin is a very potent inducer of cytochrome P450 CYP3A4 and also induces other cytochrome P450 isoenzymes, including CYP1A2, CYP2A6, CYP2B6, CYP2C8, CYP2C9, CYP2C19, and CYP3A5. Rifampin induces phase 2 drug metabolizing enzymes e.g., UDP glucuronyltransferases, sulfotransferases, and expression of transporter proteins e.g., P-glycoprotein, multiple drug resistance protein 2, organic anion transporting polypeptide. Complete induction of these isoenzymes and transport proteins occurs approximately 1 week after starting rifampin and returns to baseline approximately 2 weeks after discontinuing the drug. Rifamycins differ in their ability to induce cytochrome P450 isoenzymes, in which rifampin is the most potent, rifapentine is intermediate, and rifabutin is the least potent enzyme inducer. Rifampin increases the metabolism of protease inhibitors, certain non-nucleoside reverse transcriptase inhibitors abbreviated as NNRTs, macrolide antibiotics, azole antifungal agents, corticosteroids, oral contraceptives, warfarin, cyclosporine, tacrolimus, theophylline, phenytoin, quinidine, diazepam, propanolol, metoprolol, sulfonylureas, verapamil, nifedipine, diltiazem, enalapril, and simvastatin. Although the patient is receiving rifampin, it may be necessary to monitor serum concentrations of the aforementioned drugs, when appropriate, or increase the dosages. Also, women who are taking rifampin and oral contraceptives should use an alternative method of birth control. When treating any patient with rifampin, the healthcare professional should carefully evaluate all concomitant medications for the possibility of drug-drug interactions. Let's now consider isoniazid rifampin. We will begin with hepatotoxicity. Some initial evidence suggested that the concomitant use of isoniazid and rifampin was associated with a greater incidence of hepatotoxicity. The mechanism was thought to be attributable to rifampin induction of the metabolism of isoniazid to either monoacetylhydrazine or to other hepatotoxic products of hydrolysis. Steele et al. Performed a meta-analysis reviewing the incidence of hepatitis using regimens that contained isoniazid without rifampin, rifampin without isoniazid, and regimens containing both drugs. They found the incidence of clinical hepatitis was greater in regimens containing both isoniazid and rifampin, that is 2.7%, versus regimens of isoniazid alone, that is 1.6%, but this effect was additive, not synergistic, and therefore expected. The use of the two drugs together, therefore, is not contraindicated, but caution should be used in high-risk groups such as the elderly, alcoholics, those receiving concomitant hepatotoxic agents, and those with pre-existing liver disease. Next we will discuss ethambutol. Let's begin with optic neuritis. Patient SE's decrease in visual acuity is compatible with ethambutol-induced optic neuritis. This condition is characterized by central scotomas, loss of red-green color vision, or less commonly, a peripheral vision defect. The intensity of these ocular effects is related to the duration of continued therapy after decreased visual acuity is first noted. Optic neuritis is related to both dose and duration, and it rarely occurs at doses of 15 mg per kilogram. The incidence is estimated to be 6% for doses of 25 mg per kilogram and increases to 15% for doses in excess of 35 mg per kilogram. Recovery, which may take months, is usually, but not always, complete when the drug is discontinued. Optic neuritis manifested in patient SE is probably caused by the use of an increased ethambutol dose 18.5 mg per kilogram in a patient with impaired renal function. Because ethambutol adds no additional benefit to isoniazid and rifampin after the first 2 months for susceptible organisms, it can be discontinued. Ethambutol is excreted by the kidney, 50% to 80%, and her ethambutol dosing interval should have been increased based on the decline in creatinine clearance. Her visual acuity should be monitored closely through periodic eye examinations, and she should be instructed to contact her physician immediately if she experiences any further visual changes. Patient SE's elevated serum uric acid also may be attributed to her ethambutol as well as a decline in her renal function, but it is more likely caused by pyrazinamide, which decreases the tubular secretion of urate. Asymptomatic hyperuricemia secondary to drugs usually does not require treatment. Next we will discuss special treatment considerations. Let's begin with the elderly. Regarding the incidence, in 2014, the overall case rate of tuberculosis in adults 64 years or older was higher than all other age groups, 4.8 in 100,000 population. Similar to other age groups, the case rate for persons 64 years or older has declined every year since 1993 when the case rate was 17.7 in 100,000 population. In 2014, 2.2% of tuberculosis cases were reported in residents of long-term care facilities, and the case rate for nursing home residents is 1.8 times higher than that for elderly persons living in the community. Active tuberculosis disease in the elderly has been attributed to decreased immune function followed by reactivation of an earlier infection, but active disease is a common, endemic infection in nursing home patients with no previous immunity negative skin test to Mycobacterium tuberculosis. The incidence of positive tuberculin skin tests increases after patients have been in the nursing home longer than 1 month. Therefore, all patients entering a nursing home should be tested with 5 Tu of PPD. If the initial test is negative and a source case is present in the nursing home, as illustrated by this case, this test should be repeated in 1 month. The rate of tuberculin skin test conversion from negative to positive tests in this population is approximately 5%. If these recent converters are not treated with isoniazid, approximately 17% will develop progressive pulmonary TB. Next we will discuss the diagnosis of tuberculosis. Diagnosis of active tuberculosis in elderly patients is difficult because classic symptoms of cough, fever, night sweats, and weight loss are often absent, and elderly patients may describe their symptoms poorly. The chest radiograph and PPD skin test may be the only signs of tuberculosis infection. Frequently, the chest radiograph is atypical, resembling pneumonia or worsening heart failure. Chest radiographs in the elderly are less likely to reveal upper lobe infiltration, however, more commonly they will show extensive infiltration of both lungs. If the patient's clinical disease is caused by reactivation, the chest radiograph often shows apical infiltrates or nodules. If the disease is progressing from an initial infection, as in the case of patient GH, lower lobe infiltrates may be present. Tuberculosis in this population may present clinically with changes in activities of daily living, chronic fatigue, cognitive impairment, anorexia, or unexplained low-grade fever. Nonspecific signs and symptoms that range in severity from subacute to chronic and that persist for weeks to months must alert clinicians to the possibility that unrecognized tuberculosis is present. Sputum examination for Mycobacterium tuberculosis, and AFB smear and culture should be performed in all patients, including the elderly. We will now discuss treatment of active disease in the elderly. The principles of tuberculosis treatment are the same for the elderly as for any other age group. Because patient GH has clinical symptoms of a respiratory infection, positive sputum smears for AFB, and a positive tuberculin skin test, he should be treated with a 4-drug regimen for active tuberculosis disease. Most tuberculosis cases in elderly patients are caused by drug-susceptible strains of Mycobacterium tuberculosis. However, notable exceptions would be older patients who are from a country or region where the prevalence of drug-resistant strains is high, persons who have been inadequately treated in the past, or persons who acquired the infection from a recent contact known to be infected with drug-resistant Mycobacterium tuberculosis. Patient GH's drug regimen should include isoniazid 300 mg, rifampin 600 mg, pyrazinamide 2000 mg, and ethambutol 1600 mg daily for 8 weeks, followed by isoniazid and rifampin daily or 2 to 3 times a week for 16 weeks, via directly observed therapy. Another option might be isoniazid, rifampin, pyrazinamide, and ethambutol daily for 2 weeks, followed by twice weekly for 6 weeks, then isoniazid and rifampin twice weekly for 16 weeks. Some clinicians prefer treating the elderly with 9-month regimens of isoniazid and rifampin. Patient GH should also receive pyridoxine 10 to 50 mg with each dose. Let's now discuss adverse drug effects. Although isoniazid hepatitis is more common in elderly patients, both isoniazid and rifampin are generally well tolerated within this age group, with major hematologic or hepatic side effects occurring in 3% to 4% of patients. Therefore, serum aminotransferases should be assessed at baseline, and patient GH should be observed monthly for clinical signs of hepatitis. As discussed earlier, routine monitoring of LFTs remains controversial because transient, asymptomatic elevations do occur among the elderly. Although uncommon at 600 mg, rifampin given twice weekly may cause a greater incidence of flu-like symptoms. Because potential drug interactions with isoniazid and rifampin are possible, any medication added to the patient's regimen should be carefully evaluated. Considering that patient GH has age-related decreased renal function, signs of ethambutol-induced visual dysfunction should be monitored carefully. Let's now discuss the treatment of latent infection in the elderly. Treatment of elderly patients with positive tuberculin skin tests but no active tuberculosis disease with isoniazid 300 mg daily for 6 to 9 months is essential if a source case is present in the nursing home. Stead and colleagues reported only 1 case of active disease in patients receiving therapy for latent tuberculosis infection compared with 69 cases in untreated patients. In patients with recently converted skin tests, 1 patient in the group receiving isoniazid therapy had active disease compared with 45 who received no treatment. Daily rifampin for 4 months or weekly isoniazid plus rifapentine for 12 weeks are also acceptable regimens in the elderly. We will now look at multidrug-resistant organisms. Let's begin with definition and etiology. In the United States, isoniazid resistance was 18.9% and resistance to both isoniazid and rifampin was 7.1% in patients with previous tuberculosis in 2014. Resistance in Mycobacterium tuberculosis is either primary or acquired. Primary drug resistance occurs when a patient harbors a resistant strain before any drugs have been administered. Acquired drug resistance occurs when resistant subpopulations are selected as a result of treatment errors, such as addition of a single drug to a failing regimen, inadequate primary regimen, failure to recognize resistance, and, most importantly, non-adherence to the prescribed regimen. Sporadic ingestion, inadequate dosages, or malabsorption of medications can cause susceptible Mycobacterium tuberculosis strains to become resistant to multiple drugs within a few months. These resistant organisms can then be transmitted to persons who have never received treatment and lead to primary resistance in those patients. Patient MS is a foreign-born person of Asian ethnicity and may have primary resistance from his country of origin, making a detailed exposure history essential for the treatment of his infection. Patient MS is also an example of the problem of treatment failure caused by non-adherence and the potential development of drug-resistant organisms. Homelessness and lack of awareness of the severity of tuberculosis have been shown to be significantly associated with interruptions in tuberculosis therapy. Therefore, educational efforts to improve a patient's understanding of tuberculosis disease are critical for appropriate treatment of the disease. Many factors can affect the outcome of therapy for multi-drug-resistant TB, including HIV status, treatment adherence, the number of drugs to which the tubercle bacilli remain susceptible, and the time since the first diagnosis of tuberculosis. In one study, all 11 patients who were HIV positive died during observation. In another study, 77% of patients with multi-drug-resistant TB had sputum cultures convert to negative in a median time of 60 days range, 4 to 462 days, but 23% of patients never converted to negative cultures. Of the patients who converted, 60% converted after 4 months of therapy. Predictors of a longer time for sputum culture conversion were high initial sputum colony counts, bilateral cavitation on chest radiograph, previous treatment of multi-drug-resistant TB, and the number of drugs the initial isolate was resistant to at the beginning of therapy.
Because his recent HIV test was negative, patient MS has a higher probability of treatment success. In HIV-negative patients, 32, that is 97%, of 33 patients with multi-drug-resistant TB were cured, and these patients received an average of 5 second-line drugs. Only one relapse occurred 5 years after treatment. Therefore, MS's current regimen should be re-evaluated, drug susceptibility testing should be determined, and the patient should be referred to a specialist or consultation at a specialized treatment center. Molecular drug resistance testing should be performed to evaluate resistance to rifampin, which is a reliable surrogate for multi-drug resistant TB. Standard susceptibility testing methods should be performed for the other agents, although results may not be available for several weeks. If the rapid molecular test detects the presence of mutations to rifampin, the patient should then begin therapy for multi-drug-resistant TB. However, there is no standard treatment regimen for multi-drug-resistant TB. When revising a treatment regimen, at least 3 previously unused drugs to which the organism is susceptible should be used, and one of these agents should be injectable. A new regimen should contain at least 4 drugs, possibly more, depending on disease severity and resistance pattern. Treatment should be given by DOT, and the recommended duration is 18 to 24 months. However, only 40% of patients with multi-drug-resistant tuberculosis complete a full 18 to 24 months of therapy. The efficacy of a standardized treatment regimen for a shorter duration of therapy was evaluated in patients with documented multi-drug-resistant tuberculosis. The study population consisted of 427 patients with a mean age of 34 years. 81.5% had bilateral disease on chest radiograph, and patients had exhibited tuberculosis for approximately 30 months on average. The mean body mass index was 16.1 kilograms per meter squared, indicating severe emaciation.
The intensive phase consisted of 3 or more months of therapy with 6 to 7 agents, and doses were based on body weight. Daily ofloxacin and gatafloxacin doses were 400, 600, and 800 mg for body weights less than 33 kg, 33 to 50 kg, and greater than 50 kg, respectively. The most effective treatment regimen required a minimum of 9 months of therapy with gatafloxacin, clofazimine, ethambutol, and pyrazinamide throughout the treatment period, with the addition of high-dose isoniazid, prothonamide, and kanamycin for a minimum of 4 months during the intensive phase. Among 206 patients receiving this regimen, the relapse-free cure rate was 87.9%. The most common adverse events with this regimen were vomiting, that is 21.4%, diminished hearing acuity, that is 6.3%, dysglycemia, that is 3.9%, and ataxia, that is 3.9%. These results suggest that it may be possible to adequately treat patients with multidrug-resistant TB with shorter courses of therapy. However, prothonamide and kanamycin are unavailable in the United States. Fluoroquinolones are active against mycobacteria, including Mycobacterium tuberculosis, and they penetrate rapidly into macrophages and exhibit intracellular mycobactericidal activity. Fluoroquinolones inhibit DNA gyrase in Mycobacterium tuberculosis, but the other molecular target of these agents, topoisomerase 4, is absent. Ciprofloxacin, ofloxacin, and levofloxacin have been used long-term for the treatment of mycobacterial infections and were well tolerated with few serious adverse effects. Limited data suggest that moxifloxacin is an acceptable option in the treatment of multidrug-resistant TB. Selection of fluoroquinolone resistance has been observed in vivo, and complete cross-resistance within the class is the accepted rule. Other second-line medications used for multidrug-resistant TB include para-aminosalicylic acid, cycloserine, ethionamide, and capreomycin. These agents are associated with numerous side effects and should not be prescribed without the guidance of an expert in the treatment of multidrug-resistant TB.
Bedaquiline was FDA approved in late 2012 as part of combination therapy with at least 3 or 4 other drugs in adults with pulmonary multidrug-resistant TB when other alternatives are not available. Bedaquiline is a novel drug that inhibits mycobacterial adenosine 5-triphosphate synthase, thereby inhibiting energy production in Mycobacterium tuberculosis. The drug is available in 100 mg tablets, and the recommended dosage is 400 mg daily for 2 weeks followed by 200 mg thrice weekly for 22 weeks. Bioavailability of bedaquiline is increased twofold when administered with food, and each dose should be administered by DOT. Bedaquiline is metabolized by CYP3A4, and it is recommended to avoid concomitant administration of bedaquiline with moderate, e.g., efavirenz, and strong, e.g., rifamycins, CYP3A4 inducers. Strong CYP3A4 inhibitors may increase systemic exposure and adverse events of bedaquiline, and use of strong CYP3A4 inhibitors for more than 14 consecutive days should be avoided while the patient is receiving bedaquiline. Bedaquiline can cause QT prolongation, and additive prolongation may occur with other drugs known to prolong the QT interval. Bedaquiline received accelerated FDA approval based on the surrogate marker of time to sputum culture conversion in Phase 2 studies. In the first study, 47 patients with multidrug-resistant TB received bedaquiline or placebo added to a preferred background regimen of kanamycin, ofloxacin, ethionamide, pyrazinamide, and cycloserine or taururzidone for 8 weeks. After 8 weeks, the background regimen was continued for a total of 96 weeks. Time to sputum culture conversion was significantly reduced in the bedaquiline group, and sputum cultures were negative in 48% of patients in the bedaquiline group compared to 9% in the placebo group at 8 weeks. After 24 weeks, 81% of patients in the bedaquiline group had negative sputum cultures compared to 65.2% in the placebo group. However, after 104 weeks, treatment success was achieved in 52.4% and 47.8% of patients in the bedaquiline and placebo groups, respectively.
In the second study, 160 patients with pulmonary multidrug-resistant TB received either placebo or bedaquiline 400 mg daily for 2 weeks followed by 200 mg thrice weekly for 22 weeks with the same background regimen described previously. After 24 weeks, patients continued the background regimen for a total of 18 to 24 months. The median time to sputum culture conversion was 83 days in the bedaquiline group compared to 125 days in the placebo group, with a p-value less than 0.001. Compared to placebo, significantly more patients in the bedaquiline group had negative cultures at 24 weeks, that is 79% versus 62%, with a p-value equal to 0.008, and at 120 weeks, 62% versus 44%, with a p-value equal to 0.04. However, mortality was significantly higher in patients receiving bedaquiline 13% versus 2%, with a p-value equal to 0.02. Let's now discuss human immunodeficiency virus infection. We will begin with the treatment of active disease. HIV infection is an important risk factor for active tuberculosis disease because HIV infects and destroys CD4+ cells, leading to impaired cell-mediated immunity. The immunodeficiency allows for rapid development of active TB disease in a person who is infected with Mycobacterium tuberculosis. Tuberculosis is a common opportunistic infection in persons infected with HIV, but unlike other opportunistic infections in this population, CD4+ cell count is not a reliable predictor for risk for tuberculosis disease. Active tuberculosis disease can occur at any CD4+ cell count, but the risk increases as a patient's immunodeficiency progresses. Common symptoms of active disease, productive cough, fever, sweats, weight loss, fatigue, may be present in HIV-infected individuals, but the clinical manifestations of tuberculosis depend on the severity of the immunodeficiency at the time of presentation. Tuberculosis in an HIV-infected person will clinically resemble tuberculosis in an HIV-uninfected person if the immunodeficiency is less severe, CD4+ count greater than 350 cells per microliter. The disease will primarily be limited to the lungs in these patients, and upper lobe involvement with or without cavitation will be seen on chest radiography. However, the findings on chest radiography are markedly different in patients with advanced HIV disease. Lower lobe, middle lobe, interstitial, and miliary infiltrates are common, whereas cavitation is seen infrequently. In these patients, tuberculosis may be difficult to distinguish from other HIV-related pulmonary opportunistic infections, Pneumocystis jirovecii, Mycobacterium avium complex, and tuberculosis should be ruled out in any HIV-infected patient with pulmonary symptoms. Patients with advanced HIV disease may also have normal chest radiographs but still have positive sputum smears for AFB and positive cultures for Mycobacterium tuberculosis. Therefore, a normal chest radiograph does not exclude the possibility of active tuberculosis disease. Extrapulmonary tuberculosis is more common in HIV-infected persons with CD4+ counts less than 200 cells per microliter. Because of patient FR's clinical presentation and positive HIV test, a high index of suspicion and diagnostic workup for active tuberculosis are appropriate. A PPD skin test should be placed on HIV-infected patients with suspected tuberculosis infection, but sensitivity and specificity of skin testing are poor in patients with HIV infection. Only about 30% to 50% of patients with AIDS and tuberculosis will respond to a PPD skin test with an induration greater than 10 mm. Therefore, an induration of 5 mm or more is considered to be a positive reaction in this population. Patient FR's reaction of 6 mm to the tuberculin skin test should be considered positive. Theoretically, the sensitivity and specificity of interferon gamma release assays are also limited in patients with HIV infection because the tests depend on adequately functioning CD4+ cells. In a study of 294 HIV-infected subjects, indeterminate results were more likely to occur in subjects with a CD4+ count less than 100 cells per microliter compared with those with a CD4+ count of 100 cells per microliter or more. Additional studies found only 64% sensitivity for detection of active tuberculosis disease, and false negative results occurred in approximately 25% of HIV-infected patients with documented pulmonary tuberculosis. These studies suggest that interferon gamma release assays should not be used alone to exclude active tuberculosis in this population.
The diagnostic workup for HIV-infected persons is similar to that for HIV-uninfected persons. Chest radiography and sputum samples for AFB smear and culture of 3 sputum specimens should be obtained. Nucleic acid amplification tests can be used to assist in evaluation of HIV-infected persons with positive AFB smears, and a positive nucleic acid amplification result in a patient who is AFB smear positive likely represents active tuberculosis. Drug susceptibility testing for all first-line agents should be performed on the initial isolate for all patients, and testing should be repeated if sputum cultures remain positive after 4 months of treatment or become positive after at least 1 month of negative cultures. Susceptibility testing of second-line agents should be limited to specimens from patients who have received prior therapy, are contacts of persons with drug-resistant tuberculosis disease, have demonstrated resistance to rifampin or other first-line agents, have positive cultures after 3 months of therapy, or are from regions with a high prevalence of multidrug-resistant TB or XDR-TB. Molecular drug resistance tests may also be used to yield faster results. Patients with symptoms of extrapulmonary tuberculosis should undergo needle aspiration or tissue biopsy of skin lesions, lymph nodes, or pericardial or pleural fluid, and blood cultures for AFB should be obtained.
Given his symptoms and positive AFB smear, patient FR should be started on multiple drug therapy for treatment of active tuberculosis disease. DOT is recommended for all patients with HIV-related tuberculosis. Patient FR's treatment plan should be based on completion of the total number of doses ingested rather than the duration of therapy. Principles and recommendations for treatment of tuberculosis in HIV-infected adults are similar to those for HIV-uninfected adults, with a notable exception, shown in Table 68-2. The initial 8-week treatment phase in patient FR should include isoniazid, rifampin or rifabutin, pyrazinamide, and ethambutol administered daily by directly observed therapy, 7 days per week for 56 doses or 5 days per week for 40 doses. However, twice or thrice weekly dosing regimens during the intensive phase have been associated with increased risk of treatment failure or relapse with acquired rifamycin resistance. Therefore, intermittent dosing regimens are no longer recommended during the intensive phase. Patient FR should also receive supplemental pyridoxine. After the initial phase, if no drug resistance is evident on susceptibility or molecular testing, patient FR can be treated with isoniazid and rifampin or rifabutin daily or 2 to 3 times a week by directly observed therapy for a minimum of 26 weeks. Although not applicable to patient FR because his CD4+ cell count is 150 cells per microliter, it should be noted that twice-weekly continuation therapy with isoniazid and rifampin or isoniazid and rifabutin is not recommended for HIV-infected patients with a CD4+ count less than 100 cells per microliter because of an increased frequency of acquired rifamycin resistance. Twice-weekly administration in the continuation phase may be considered in patient FR because his CD4+ count is greater than 100 cells per microliter, but the data supporting this recommendation are limited, shown in Table 68-2. In addition, the once-weekly continuation regimen of isoniazid and rifampin is contraindicated in HIV-infected patients because of a high rate of relapse with organisms that have acquired resistance to the rifamycins. A randomized clinical study evaluated the efficacy of 6 months and 9 months of fully intermittent therapy in HIV-infected patients with tuberculosis. All patients received 2 months of isoniazid, rifampin, pyrazinamide, and ethambutol, and then patients were randomly assigned to receive either 4 months N equals 167 or 7 months N equals 160 of isoniazid and rifampin. Throughout the study duration, doses were administered thrice weekly. The median viral load was 155,000 copies per milliliter, and the median CD4+ cell count was 160 cells per microliter. Favorable clinical response was similar between the two groups, however, bacteriologic recurrence occurred significantly less frequently in the 9-month group compared with the 6-month group, 7% versus 15%, with a p-value less than 0.05. These data may provide support for 9 months of therapy if a fully intermittent regimen is prescribed for tuberculosis therapy in HIV-infected patients. If patient FR had cavitary disease on chest radiography or if cultures are positive after 2 months of therapy, treatment with isoniazid and rifampin or rifabutin should be continued to complete a total of 9 months of therapy. If patient FR was suspected of having extrapulmonary disease caused by drug-susceptible strains, the recommended treatment is isoniazid, rifampin, pyrazinamide, and ethambutol for 2 months followed by isoniazid and rifampin for 4 to 7 months. However, longer durations of therapy are recommended for extrapulmonary tuberculosis involving the CNS, that is meningitis or tuberculoma, or bone and joints. For these infections, many experts recommend 9 to 12 months of therapy. Baseline and monthly evaluations of hepatic function, renal function, complete blood count, and CD4+ cell count are recommended in all HIV-infected patients with active tuberculosis disease. In the absence of symptoms, elevations of AST 3 times the upper limit of normal in a patient with symptoms, greater than 5 times the upper limit of normal regardless of symptoms, or if a significant increase in alkaline phosphatase and/or bilirubin occurs, hepatotoxic drugs should be stopped and the patient evaluated. For pulmonary tuberculosis, at least one sputum specimen should be obtained monthly for AFB smear and culture until 2 consecutive specimens are culture negative. If the AFB smear is positive at the initiation of treatment, AFB smears may be obtained every 2 weeks to provide an early assessment of bacteriologic response to therapy.
Results of sputum samples obtained after the initial 8-week treatment phase are important because determination of the duration of the continuation phase will be based on these results. Susceptibility testing should be performed on all isolates, and susceptibility testing should be repeated on a newly obtained sputum sample if cultures are positive for Mycobacterium tuberculosis after 3 months of therapy. Patients with positive cultures at or after 4 months of therapy should be considered treatment failures. At every visit, patients should be questioned about adherence to therapy and possible adverse events to the treatment regimen. If a patient is experiencing adverse events, the first-line drug should not be discontinued permanently without strong evidence that a specific agent is the cause of the adverse event. Drug concentration monitoring may be useful to help guide therapy in patients who respond slowly to the prescribed treatment regimen.
Optimal management of active tuberculosis disease in patients infected with HIV requires treatment of both infections. Sequential treatment of tuberculosis followed by treatment of HIV is not recommended. In patients with HIV infection, CD4+ cells multiply in response to Mycobacterium tuberculosis, and then HIV replication accelerates within the lymphocytes and macrophages, which leads to progression of HIV disease. Therefore, initiation of ART can prevent progression of HIV disease and reduce morbidity and mortality associated with tuberculosis and other opportunistic infections. However, this approach may be associated with cumulative drug toxicities, significant drug interactions, a higher pill burden, and the potential for development of immune reconstitution inflammatory syndrome (IRIS). 3 studies addressed the optimal timing to initiate ART during the treatment of active tuberculosis disease. In ART-naive patients, ART should be initiated within 2 weeks of starting tuberculosis therapy in patients with a CD4+ count less than 50 cells per microliter. Early initiation of ART significantly reduces mortality in these patients, but the risk of IRIS is increased. In patients with CD4+ counts of 50 cells per microliter or greater who present with severe tuberculosis disease, low Karnofsky score, low body mass index, low hemoglobin, low albumin, organ system dysfunction, or extensive disease, ART should be initiated within 2 to 4 weeks of starting tuberculosis therapy.
In patients with CD4+ counts of 50 cells per microliter or greater who do not have severe tuberculosis disease, ART should be initiated within 8 to 12 weeks of initiating tuberculosis therapy. If IRIS develops, neither therapy for tuberculosis nor HIV should be discontinued. Because patient FR is ART naive and his CD4+ count is 150 cells per microliter, ART should be initiated within 8 to 12 weeks of starting treatment for active tuberculosis. If patient FR was receiving ART when diagnosed with tuberculosis, treatment for tuberculosis should be started immediately, and ART should be modified to maintain virologic suppression while reducing the risk for drug-drug interactions. ART should not be withheld simply because the patient is being treated for TB, and a rifamycin should not be excluded from the treatment regimen for fear of interactions with certain antiretroviral agents. Exclusion of a rifamycin will likely delay sputum conversion, prolong the duration of therapy, and possibly result in a poor outcome.
Immune reconstitution inflammatory syndrome, or IRIS, occurs in approximately 30% of patients who begin therapy for both HIV and tuberculosis in close temporal proximity. This syndrome is thought to reflect recovery of immune responses to Mycobacterium tuberculosis and usually occurs in the first 1 to 4 weeks after initiation of ART. Iris lasts for 2 to 3 months on average, but some patients may experience iris symptoms for months. The immune response can be an exaggerated inflammatory response during tuberculosis therapy in a patient known to have tuberculosis infection, or it may unmask a previously undiagnosed tuberculosis infection. The risk of iris is greater when ART is initiated within the first 2 months of tuberculosis therapy and when the CD4+ count is less than 100 cells per microliter. Symptoms include high fever, malaise, and local reactions in organs, depending on the location of the mycobacterial infection, e.g., lungs, lymph nodes, and CNS. Iris is usually self-limiting, but supportive therapy may be required if symptoms are severe. Moderate iris reactions should be treated with nonsteroidal anti-inflammatory drugs without any changes to tuberculosis therapy or ART. No specific treatment recommendations are available for severe iris, however, prednisone or methylprednisolone at doses of 1 mg per kilogram body weight and tapered for 1 to 2 weeks has been beneficial. Simultaneous treatment of tuberculosis and HIV can be complicated by drug interactions with the rifamycins and ART. Rifampin is a potent inducer of cytochrome P450 isoenzymes, but rifabutin is not a potent inducer. Rifabutin is highly active against M. tuberculosis, and data from clinical trials suggest equal efficacy with rifampin and rifabutin-based treatment regimens. Because of fewer drug interactions and documented efficacy, rifabutin is recommended in place of rifampin for the treatment of active tuberculosis in HIV-infected patients receiving certain protease inhibitors or NNRTIs. However, some antiretroviral agents may either induce or inhibit cytochrome P450 isoenzymes, depending on the specific drug, and may alter rifabutin serum concentrations. For the NNRTIs, rifampin was shown to decrease efavirenz exposures by 26%, but 2 additional studies did not show a significant effect of rifampin on efavirenz exposure. Therefore, the preferred treatment regimens are rifampin-based tuberculosis therapy with an ART regimen consisting of efavirenz plus 2 nucleoside reverse transcriptase inhibitors. The efavirenz dose should be 600 mg daily. Efavirenz decreases rifabutin exposure by 38%, necessitating a dosage increase for rifabutin to 450 to 600 mg daily. For patients unable to take efavirenz due to early pregnancy or intolerance, nevirapine-based ART can be used, but rifampin significantly decreases nevirapine exposures. If used concomitantly, the nevirapine dose should be 200 mg twice daily. However, rifabutin-based tuberculosis therapy may be considered with a nevirapine-based ART regimen because dosage adjustments are not needed for either agent. Concomitant administration of etravirine and rilpivirine with rifampin should be avoided due to significant reduction in exposures of these NNRTIs. Rifampin should not be used in patients receiving protease inhibitor-based ART, regardless of boosting with ritonavir, because rifampin causes a dramatic decrease in exposures of the protease inhibitors. Rifabutin has a negligible effect on ritonavir-boosted lopinavir or atazanavir and only moderate increases in darunavir and fosamprenavir concentrations. For patients unable to tolerate efavirenz or nevirapine or if the HIV strain is resistant to NNRTIs, a rifabutin-based tuberculosis regimen is preferred with an ritonavir-boosted protease inhibitor regimen. However, all protease inhibitors markedly increase rifabutin concentrations. If doses of rifabutin are not adjusted, adverse drug events, such as uveitis, neutropenia, arthralgias, skin discoloration, may occur. Therefore, the rifabutin dose should be decreased to 150 mg daily when administered with protease inhibitors.
HIV nucleoside and nucleotide reverse transcriptase inhibitors and the fusion inhibitor enfuvirtide are not metabolized by CYP isoenzymes. As a result, these agents can be administered with the rifamycins. Rifampin decreases the concentrations of the integrase inhibitors, raltegravir and elvitegravir. The raltegravir dose should be increased to 800 mg twice daily, but no dosage adjustment is recommended with rifabutin. Co-administration with elvitegravir with rifampin and rifabutin should be avoided. Maraviroc, a CCR5 antagonist, is a substrate for CYP3A and P-glycoprotein, and concomitant administration with rifampin significantly decreases exposures. The Maraviroc dose should be increased to 600 mg twice daily, but no dosage adjustment is needed with rifabutin. Next we will discuss the treatment of latent tuberculosis infection in human immunodeficiency virus infection. The risk of patient NM developing active tuberculosis disease is significant, therefore, he should receive treatment for latent tuberculosis infection. HIV-infected persons, regardless of age, should be treated for latent tuberculosis infection. HAPE al. conducted a randomized, placebo-controlled trial of isoniazid therapy in HIV-infected patients. Patients receiving placebo were 6 times more likely to develop active tuberculosis than those receiving isoniazid, and patients receiving isoniazid were also less likely to develop AIDS. The preferred treatment for latent tuberculosis infection in patient NM is isoniazid 300 mg daily or twice weekly for 9 months. Isoniazid does not increase the risk of hepatitis when used with efavirenz or nevirapine-based ART regimens. Patient NM should also receive pyridoxine 25 mg daily to prevent peripheral neuropathy. Rifampin and rifabutin for 4 months are alternatives to isoniazid, but the potential for drug interactions should be considered. Weekly isoniazid plus rifapentine are not recommended for HIV-infected patients due to the potential for significant drug interactions with rifapentine and ART.
We will now look at pregnancy. Although concerns about the use of any medication during pregnancy always exist, it is now recognized that untreated tuberculosis represents a far greater risk to a pregnant woman and her fetus than the treatment. TB is one of the leading non-obstetric causes of maternal mortality. The World Health Organization recommends that treatment of tuberculosis in pregnant women should be the same as that for non-pregnant women, with few exceptions. Isoniazid, rifampin, pyrazinamide, and ethambutol are not teratogenic in humans. In the United States, pyrazinamide is not recommended for use during pregnancy because of insufficient safety data. If pyrazinamide is not included in the initial treatment regimen, the minimal duration of therapy is 9 months. All pregnant women receiving isoniazid should also receive pyridoxine 25 mg per day because of the possibility of peripheral neuropathy. Streptomycin should not be used during pregnancy except as a last alternative because it has been associated with mild to severe ototoxicity in the fetus. Ototoxicity can occur throughout the gestational period and is not confined to the first trimester. With the exception of streptomycin ototoxicity, the occurrence of birth defects in women being treated for tuberculosis with the above agents is no greater than that of healthy pregnant women. Therefore, administration of antituberculosis drugs is not an indication for termination of pregnancy. Because patient EF likely became pregnant after completing the first 2 months of therapy, she should continue her current regimen for a total of 6 months because she received pyrazinamide as part of the initial regimen.
Next we will discuss multidrug-resistant tuberculosis in pregnancy. Little is known about the efficacy and safety of second-line drugs for the treatment of multidrug-resistant tuberculosis during pregnancy. 2 reports with small numbers of patients have suggested that treatment is effective with no adverse effects to mother or child. In a study of 7 women treated for multidrug-resistant tuberculosis during pregnancy, no obstetric complications or perinatal transmission of multidrug-resistant tuberculosis was observed. 5 women were cured, 1 experienced treatment failure, and 1 stopped therapy prematurely. No evidence of drug toxicity was seen among their children exposed to second-line drugs in utero, although 1 child was diagnosed with multidrug-resistant tuberculosis. There are no well-controlled studies with bedaquiline in pregnancy. Therefore, the drug should only be used in pregnancy if clearly needed. More data are needed, but pregnancy should not be a limitation to the treatment of multidrug-resistant tuberculosis. We will now move on to lactation. When the baby is born, patient EF may breastfeed while continuing her medication. Drug concentrations in breast milk are minimal and do not provide sufficient quantities for the treatment or prevention of tuberculosis in the nursing infant.
We will now proceed to pediatrics. The incidence of tuberculosis in children younger than 15 years of age has declined from 1,660 cases, 2.9 in 100,000 population in 1993 to 460 cases, 0.8 in 100,000 population in 2014. Children commonly have active tuberculosis disease as a complication of the initial infection with Mycobacterium tuberculosis, and the disease is characterized by intrathoracic adenopathy, middle and lower lung lobe infiltrates, and the absence of cavitation on chest radiography. Because of the high risk of disseminated tuberculosis in infants and children, treatment should be started as soon as the diagnosis of tuberculosis is suspected. In general, regimens recommended for adults are also recommended for infants, children, and adolescents, with the exception that ethambutol is not used routinely in children. Ethambutol is often avoided because it is difficult to assess visual acuity in children. Patient AM should be started on isoniazid 10 to 15 mg per kilogram per day, rifampin 10 to 20 mg per kilogram per day, and pyrazinamide 15 to 30 mg per kilogram per day. Many experts prefer to treat children with 3 drugs rather than 4 in the initial phase because the bacillary population is usually lower than in an adult and it may be difficult for an infant or child to ingest 4 drugs. If resistance is suspected, ethambutol 15 to 20 mg per kilogram per day or streptomycin 20 to 40 mg per kilogram per day should be added to the regimen until susceptibility of the organism to isoniazid, rifampin, and pyrazinamide is known. Pyridoxine is recommended for infants, children, and adolescents who are receiving isoniazid. If resistance is not suspected and drug susceptibility is confirmed, AM should receive the isoniazid, rifampin, and pyrazinamide daily for 8 weeks. He can then continue to take the isoniazid and rifampin daily or 2 to 3 times a week using directly observed therapy for an additional 4 months. The dosage for isoniazid and rifampin in a 2 to 3 times a week regimen would be 20 to 30 mg per kilogram per dose and 10 to 20 mg per kilogram per dose, respectively, shown in Table 68.3. Patient AM should be examined routinely for signs and symptoms of hepatitis. Although anti-tuberculosis medications are generally well tolerated in children, LFTs are commonly 2 to 3 times the upper limit of normal during therapy. These are often benign and transient. However, the incidence of hepatitis in children from isoniazid with rifampin may be 4 to 6 times more common than in children receiving isoniazid alone. Most hepatitis occurs within the first 3 months of therapy and generally is associated with higher than recommended doses of isoniazid or rifampin. Children and adolescents should be screened for risk factors for tuberculosis using a questionnaire, and they should be skin tested with 5-Tu of PPD if one or more risk factors are present. Insufficient data are available to recommend use of interferon gamma release assays in children. Isoniazid for 9 months is recommended for treatment of latent tuberculosis in this population. Daily rifampin for 6 months is an acceptable alternative, especially in children who cannot tolerate isoniazid or those exposed to a source case whose isolate was isoniazid resistant. Next we will discuss extrapulmonary tuberculosis and tuberculous meningitis. Tuberculous meningitis is only one of the extrapulmonary complications of infection with Mycobacterium tuberculosis. Successful treatment of extrapulmonary tuberculosis can usually be accomplished in 6 to 9 months with an acceptable relapse rate. Some forms, such as bone or joint tuberculosis, miliary tuberculosis, or tuberculous meningitis, may require 9 to 12 months of therapy. Because specimens for culture and susceptibility testing may be difficult or impossible to obtain from a site, response to treatment must be based on clinical and radiographic improvement. Tuberculous meningitis in older persons is usually caused by hematogenous dissemination of the tubercle bacilli from a primary site, most commonly the lungs. In its early stages, tuberculous meningitis often is confused with aseptic meningitis because the Gram stain is negative. The most common symptoms of tuberculous meningitis are headache, fever, restlessness, irritability, nausea, and vomiting. A positive Brudzinski sign and neck stiffness may be present. As illustrated in patient RU, the CSF is usually turbid with increased protein and decreased glucose concentrations. There is an increase in the CSF white blood cell count with a predominance of lymphocytes. Culture of the CSF for Mycobacterium tuberculosis may not be helpful because rates of positivity for clinically diagnosed cases range from 25% to 70%. Early recognition and treatment are essential for a favorable outcome. Thus, empirical treatment before receipt of confirmatory culture and susceptibility results is common in suspected tuberculous meningitis. Multiple drug therapy should be used because irreversible brain damage or death can occur as soon as 2 weeks after the onset of infection, not clinical symptoms. We will now discuss its treatment. Treatment should be initiated in patient RU with daily administration of isoniazid 300 mg, rifampin 600 mg, pyrazinamide 2000 mg, and ethambutol 1600 mg for the first 8 weeks. 33 After this initial phase of treatment, patient RU should receive daily isoniazid and rifampin for an additional 7 to 10 months, although the optimal duration of therapy is unknown. In addition, because patient RU is older, pyridoxine 10 to 50 mg per day should be given to prevent the occurrence of peripheral neuropathy from isoniazid. It should be reiterated that rifampin can impart a red to orange color to the CSF. Isoniazid readily penetrates into the CSF, with CSF concentrations reaching up to 100% of those in the serum. Rifampin is often included in tuberculous meningitis regimens and may be associated with reduced morbidity and mortality. However, even with inflammation, CSF concentrations of rifampin are only 6% to 30% of those found in the serum. Ethambutol should be used in the highest dosage to achieve bactericidal concentrations in the CSF because its CSF concentrations are only 10% to 54% of those in the serum. Streptomycin penetrates into the CSF poorly even with inflamed meninges. We will now briefly discuss corticosteroids. Corticosteroids in moderate to severe tuberculous meningitis appear to reduce sequelae and prolong survival. The mechanism for this benefit is likely owing to reduction of intracranial pressure. Dexamethasone 8 to 12 mg per day, or prednisone equivalent, for 6 to 8 weeks should be used and then tapered slowly after symptoms subside. Corticosteroids are likely indicated for patient RU. Next we will discuss therapeutic drug monitoring. The pharmacokinetics of the drugs used to treat tuberculosis are highly variable and depend on weight, sex, genetic traits, and underlying comorbidities. Subtherapeutic concentrations may be associated with a delayed response to therapy, increased risk of relapse, or acquired drug resistance. Several studies measured drug concentrations in patients with slow clinical response to tuberculosis treatment and found subtherapeutic concentrations for isoniazid, rifampin, ethambutol, and rifabutin in a substantial percentage of patients evaluated. In one study, time to sputum culture conversion was longer in patients with low serum concentrations. In a prospective observational study, 2-hour plasma concentrations were measured in 35 patients, and plasma concentrations were below the normal ranges in 71%, 58%, 46%, and 10% of patients for isoniazid, rifampin, ethambutol, and pyrazinamide, respectively. In addition, 45% of patients had subtherapeutic concentrations for both isoniazid and rifampin. Treatment failure occurred significantly more frequently when concentrations of isoniazid and rifampin were below the normal ranges with a p-value equal to 0.013, and below the median 2-hour drug concentration achieved in the study, with a p-value equal to 0.005. In 142 patients with active tuberculosis, poor long-term outcomes were predicted by a 24-hour area under the concentration time curve AUC equal to or less than 363 mg/hour. L for pyrazinamide is less than or equal to 13 mg/hour per liter for rifampin, and equal to or less than 52 mg/hour per liter for isoniazid. Poor outcomes occurred in 32 out of 78 patients with at least one drug with an AUC below these threshold values compared to 3 out of 64 patients without any low patient AUCs. Odds ratio equals 14.14, with a 95% confidence interval of 4.08 to 49.1. Low rifampin and isoniazid peak concentrations and AUCs predicted acquired drug resistance in all cases. Based on these studies, therapeutic drug monitoring may be useful in patients with poor or slow clinical response to therapy and allow for dosage adjustment to achieve therapeutic drug concentrations. Additional patients who may benefit from therapeutic drug monitoring include those with severe disease, diabetes, HIV infection, renal dysfunction, and hepatic dysfunction. A 2-hour post-dose blood sample can be obtained to estimate the peak concentration for most drugs, whereas a 3-hour post-dose blood sample would be needed for rifabutin. A second blood sample at 6 hours post-dose, 7 hours for rifabutin, may also be obtained. Trough concentrations for most agents are below the detection limit of the assays at the end of a dosing interval and are not useful clinically. Blood samples should be collected in red top test tubes and processed promptly because some drugs are not stable at room temperature in blood or serum. Once the drug concentrations are known, comparisons can be made to the normal ranges for each drug and doses adjusted accordingly. However, normal ranges for drug concentrations have not been studied in regard to clinical outcome, and optimal drug concentrations for clinical and microbiologic efficacy are not known. Although therapeutic drug monitoring may provide useful information, clinicians must remember that serum concentrations are only one factor among multiple factors affecting treatment outcomes. Thank you.